like a small boat on the ocean, sending big waves into motion, like how a single word can make a heart open. I might only have one match, but I can make an explosion. And all those things I didn't say were wrecking balls inside my brain. I will scream out tonight. Can you hear my voice this time? This is my fight song. Take back my life song. Prove them right song. My power is turned on. Started right now. I'll be strong. I'll play my fight song. And I don't really care if nobody else believes, 'cause I've still got a lot of fight left in me. All right, good morning, everybody. Happy Wednesday. Hope you guys are all doing well. Happy week 12? Week 12. All right, how are we doing?
Good. How are you?
I am hanging in there. I'm wishing it was warmer, but what can you do?
I know it was like so warm here in Utah and Salt Lake. And then yesterday was so cold and windy and rainy. But like I love the rain because I feel like I can just stay inside and study and not like wanting to be out in the sun.
No FOMO, right? Do you guys lose power yesterday? Oh, I thought I saw something happened with power outage. I don't know. I have to read some of the stuff because it doesn't concern me. But I was listening to the radio yesterday and I thought this was interesting. They rated the states with like the least amount of stress, and Utah was the state with the least amount of stress, which I thought was really interesting. I was like, oh, how cool. And Wisconsin was like right below that. I think the only states that were above us were Utah, they said, North Dakota, and Minnesota. So Midwest apparently doesn't have much stress either. So, well, we'll see how that goes. Yes, we definitely need more positivity in the world. I know I'm not always the most positive person, but we gotta try. Just makes the day go by better. In a world where you can be anything, be kind. I had that line on my TikTok for a while, then I took it down because I got sick of it. All right, so let's see. You guys saw the announcement. I moved the review from today to tomorrow. I didn't know you guys had to sign up for your capstone, and I didn't want that to interfere in any way. So we moved it to Thursday. And I know some people are taking the OB exam tonight too. So it just made more sense to move it to Thursday. I'll be hosting it. I don't know if I'm going to do Jeopardy. I was really having a hard time putting it together. Like I got really mad and I started like throwing things because I couldn't figure out how I wanted to organize like categories and stuff, and it was frustrating to me. So right now I have some other ideas that I'm like putting back and forth, but yeah, that'll be tomorrow at 6. Same Zoom ID that was posted. The exam is going to be on obesity, diabetes, and GU, the stuff we go over this week, and it's a very quick turnaround, I know, but otherwise you guys would have had all your ATIs plus COTAC and then finals right after that. So this was the best way to kind of spread it out a little bit, I guess. There's no good way to do it without, there's just not a good way. So that's where we're at. Grades are all updated. If there's anything you want to set up time to meet with me, I have a little bit of time this week too. If times don't work for you, let me know. If there's stuff that you're concerned about or things you want to go over, just let me know. And I can do my best to accommodate with that. Minus Friday. My son has his first high school baseball game on Friday. Yay! Very excited. He's a freshman, so it's very stressful. He goes to a very, very big high school. There's like 600 kids in his freshman class alone. So to make a team is very exciting. So that's my positive news for today. So yeah. Any other questions, comments, concerns, anything we need? It'll make me talk to myself. Cool. All right. Well, then we will dive right into the GU system. It's probably actually my favorite system, but I'm biased because I worked in transplant. So I got to see so much of like life being given back with kidney transplants and things like that. So I get very excited about urine. I'm very passionate about urine just because intake and output is so important. So when in doubt with GU, I don't want to say pick eyes and nose, but it's really important with GUs. If we're worried about a GU problem, eyes and nose are our intervention here. So, all right, let's jump right in. Where are my notes? So kidneys. Kidneys are the martyr of the GU system. Oh, that's awesome, Kaylee. They take a lot of damage, and any dysfunction weighs heavily on the rest of the body because the functions of the kidneys impact so many other systems. Now, the GU system isn't just the kidneys. It includes the ureter and the bladder. But I think we typically always think of the kidneys because once the kidneys go, we got some problems. So functions of the GU system. So urine formation, we all know that. Kidneys make the urine, dumps it out to the bladder, dumps it out to the urethra, we're good to go. So urine is formed in the nephrons by glomerular filtration. So that's when we talk about GFR. Tubular reabsorption and tubular secretion. Protein and glucose should not be in the urine. I repeat, protein and glucose should not be in the urine. If they are, that usually means we have some other problem going on. And that would require further investigation, putting on our thinking caps and being like, all right, why do we have glucose in the urine? More often than not, it's diabetes, but let's do some investigating. Kidneys also help with regulation of getting rid of water. This is really important job of the kidneys. When we have a high amount of fluid intake, we're taking in all this fluid, a large amount of dilute urine is going to be excreted. And then the opposite is true. If we're not drinking, a small amount of concentrated urine would be let out. A person usually ingests about 1,300 mLs of oral liquids a day and 1,000 mLs of water via food. We lose 900 in the skin. That's that insensible loss. Like it just kind of absorbs out. It's not sweat, that's something else. And we lose some through feces. 1 liter of fluid is approximately 1 kilogram, which is 2.2 pounds. So we care very much. Yes.
What is like the normal urine output per day for a human, like a normal human being?
Oh, that can vary. Bare minimum is 30 mLs of urine an hour. So 30 times 24 is whatever that math is.
Oh, okay. Awesome. Thank you.
Mm-hmm. So if your patient is producing less than 30 mLs an hour, that's an issue. And we know we're not making enough urine. So yeah, good question. Kidneys also help with regulation of the electrolytes. When the kidneys are functioning normally, the volume that the kidneys will excrete or pass through will match what they take in. One of the big jobs that the kidneys do is acid base. They help with the regulation of the acidity and basicness in the body, maintaining that homeostasis. So they help reabsorb and return any bicarb needed to the body. And when we see issues with acid base, we look at the kidneys. Is there an issue with them? And there can be a lot of acid base problems when the kidneys aren't functioning properly. Blood pressure. Remember how important blood pressure is. If there's a kidney problem, they're failing, not working well, we're going to see a rise in blood pressure. So most often our kidney failure patients are going to have really high blood pressures. That RAA pathway has been disturbed. The vasa recta is what is like the monitor. It's like the sensor in the kidneys, and that triggers renin being produced or holding back and saying, no, 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 we're good, we're good, we're good. And then failure of that biofeedback loop is when we're going to start to see hypertension. So when the kidneys are failing, hypertension is going to occur. Kidneys also help with blood cell production. The kidneys can tell when there's not enough oxygen in the body. When the kidneys aren't getting enough oxygen, they're going to release either erythropoietin, which will stimulate red blood cell production and say, hey, we need more hemoglobin and hematocrit. So if there's not enough oxygen in the body, erythropoietin will be released, which will stimulate red blood cell production because hemoglobin carries oxygen. Vitamin D in the kidneys is where vitamin D is synthesized into the active form, and we need that to balance with calcium. Urine storage, the bladder holds the urine. We go to the bathroom because we get the urge. We feel it. Something tells our brain, hey, you need to go pee. Okay. Someone who has an injury between T10 and T12, they might not be aware that they have to go to the bathroom. So there can be some incontinence issues. And micturition is the act of urinating. I think that's a great word. We go to the bathroom 8 times in a 24-hour period, or we should. You are not a baddie if you're like, oh yeah, I didn't pee my whole 12-hour shift. That's just dumb. I've heard people say that. It's like you're going to give yourself an infection. Go to the bathroom. Take your time. Go empty out your bladder. So there we go. What else do we do? When we go to the bathroom, we're going to excrete the waste, and that's what it does. So a lot of jobs. So not just urination. Other things to consider, because we care about all ages of clients, especially the adults, is the differences when people age. There will be changes in the upper and lower urinary tract functions as people get older. The GFR is going to decrease. That's that filtration rate. There'll be decreased blood flow. They're more susceptible to acute and chronic kidney injuries because of these structural and functional changes within the kidney. Urinary incontinence happens in about 15 to 30% of older adults. Over 50% of hospitalized older adults, institutionalized, and 30% of those who are hospitalized. I want to stress to you that urinary incontinence is not normal. We see it, it occurs, but it's not something that we should say, oh yeah, they're incontinent because they're old. That doesn't make sense. Not everybody will go through this process. It does happen, but we can't say like that's the reason because of it. There's other reasons, like the changes in what's going on with their kidneys, their blood flow, and whatnot. Other things that we need to be considering of incomplete incomplete emptying of the bladder. So they go to the bathroom and they don't empty it completely. We see this a lot with BPH, which is benign prostatic hypertrophy. This happens in men, only in men, because women do not have prostates. But the prostate gets large, it gets hardened, and it creates a smaller pathway for urine to get out. So not all the urine can get out. They think that they're done. Well, the urine isn't all out and it stays there. We also see issues with vaginal and ureteral atrophy in women because of decreased estrogen. So after menopause, when we're not having the estrogen produced in the same manner, we can see some of that stuff starting to happen. So those would be causes of why incontinence could potentially be happening, but it's not, it shouldn't just be expected. We will also see decreased drug clearance. The kidneys filter a lot, right? If the kidneys aren't filtering as much as they should, they might hold on to more of a drug than somebody who whose kidneys are working. Sorry, I'm stuttering. So if the kidneys aren't functioning as well, they're going to hold on to more of a med, which means we have more potential for drug-drug interactions or increased effects, if that makes sense, because there's more of it in the body. All right, questions on that? I'm going to skip this polling question because I didn't like it. And now okay, let me preface this. I'm so sorry. I moved stuff around and I added stuff because I didn't like the flow of it. So if things are different than your slides, don't freak out, because they are. I just like the way that this goes a little bit better. Okay, so bear with me. And I added some things. So we're going to talk about diagnostic studies first. First and foremost are blood tests. The BUN and creatinine, these are our gold standards. They go hand in hand. They're like hematocrit and hemoglobin. They go together. Very rarely do we talk about one without talking about the other, but they tell us what's going on with the kidney. With the creatinine, kidney disease is the only thing that will increase creatinine. The bad thing about creatinine is that we don't see a rise in the creatinine level until we get to 50% loss of function of the kidneys. So it's not the greatest like early indicator, okay? The BUN, when we see a rise in that, that can tell us more quickly that something is going on with the kidneys. But when we're looking at kidney function, these are the two that we look at. Urine analysis, these are our big ones. You need to know the terms of urination. There is a table, 53-3. I don't know what page it's on because you guys all use the ebooks and I don't know if they're the same. 53-3, know those terms. You need to understand anuria, we're not making urine. Oliguria, not enough urine. Polyuria, whole lot of urine. Whatever's in that table, be comfortable with those terms. You will see them again. Also, table 53-1, there's it's about risk factors for renal and urologic disorders. Just take a look at it, okay? Maybe it'll help connect some dots here.
Could you write that in the chat, those table names?
Sure.
Thanks.
53-3 and 53-1. All right, so a UA. We have all given urine for something at some point. A urine analysis gives us a lot of information, okay? I want to make sure that you guys understand a UA is different than a culture and sensitivity, okay? A UA we do first. It will tell us if there's protein, glucose, if there's an infection present, so like leukocytes and nitrites. What else? Blood, Billy, those little strips that we dip into the urine. That's a urine analysis. A culture and sensitivity is we do when there are bacteria present. So if there's no bacteria in the urine, we're not going to do a culture because there's no bacteria. Okay, so not every UA is going to have a culture and sensitivity, but if there is bacteria present, then we're going to do that. Did you guys get to do that in micro, where you got to take a bacteria and rub it on an agar, maybe, and then kind of see what antibiotics would take care of it? That's what they do. That's what this is. So they drop the urine, rub it all over the agar, and then they put little different antibiotic discs all over to see which antibiotic it's sensitive to, so they know which ones they can prescribe based off of comorbidities and allergies and whatnot, because the lab doesn't have that information. So it's kind of cool. So with a UA, I'm going to backtrack now. We look at the color. Urine should be pretty pale yellow, colorless. That means we're getting enough fluid. It's dilute. We don't want it clear because that means we're definitely dilute, but it should be a light in color. Yellow to milky yellow usually means that there's an infection. So like pus in the urine, pyuria, or like a vaginal cream. If they had something going on and they were using a cream when they voided it out, it can change the color of the urine. Bright yellow. Bright yellow happens when we have too many vitamins present and your body just flushes them out. You guys ever have too many energy drinks? Like too many Monsters, too many Red Bulls. You guys are laughing. Your pee turns like bright, toxic, like electric colors. That's what we're talking about. If this hasn't happened to you, please don't go run out and do it because I don't want anybody to have like heart palpitations. But there's so many vitamins in some of those energy drinks, it can change the color of your urine. So that's what I always think of when I think about that. Pink or red usually is an indication that there's probably blood or hemoglobin breakdown. We can see this with menses or from a UTI, like if it's causing issues, medications, and foods. Beets and blackberries can change the color of the urine, especially if you eat a lot of them. Or certain medications can change the urine color as well. If the urine is blue or green, that means they've come into contact with potentially a dye like methylene blue, which is the craziest thing. You can walk into a patient's room when they come back from a procedure and there's just like blue in the urine bag and you're like, oh, that looks like antifreeze. That can't be good. But yeah. Pseudomonas actually can change the color of the urine too, which is not a bacteria we like, especially in the urinary tract, but it can change the color. Or amitriptyline, which is a tricyclic antidepressant, can change the urine as well. What else? Orange or amber, that's usually more concentrated, so we're not getting enough fluid. So we see that a lot with more like dehydration or with fever or some viral illnesses, or sometimes some liver issues, like it's flushing out bilirubin or urinating out bilirubin.
Hey, Amy.
Yeah.
I was just gonna say, I work in primary care, so we see like UTIs and like bladder infections a lot. And you may see some people can get like azo over the counter. It's called azo, or other like over the counter UTI treatments, and that'll turn their urine orange. So if they've taken it like within 24 hours of when they came in, it may still be orange and it's hard to read the dipstick. So just a heads up.
Yes, it is. Or pyridium will it turns your secretions orange, which includes your urine. So then we do further investigation. More questions. What meds have you been taking? Urine has an odor, but it doesn't. Like if you're properly hydrated, it doesn't smell terrible. But have you guys ever walked onto a unit and you smell the UTI? Some UTIs just have a very pungent, like, odor to it. And we can tell. You can smell somebody in one of these rooms has a UTI. So you shouldn't be smelling too much. Specific gravity is the concentration of the urine. And this can change due to blood or protein or CAS that can be present in the urine. When we do the dip, that's where we get those numbers from. Again, we don't want ketones, blood, and protein in the urine. They shouldn't be. And drugs, well, we can do drug screens. You guys have all done them for school, so you know exactly what they're talking about. It's the same thing. They stick a stick in there, they test for drugs. They can do medications, they can do illegal drugs, that sort of thing. And then the 24-hour urine collection. Remember those key components. Flush the first void, collect everything for 24 hours, keep it on ice. Those are your big takeaways. Keeping stool and toilet paper out of there as well. Midstream urine collections. These really only go well if you're a man, but they're it's an important teaching that we have to do. When we collect midstream urine, we want the midstream. We don't want what first comes out of the urethra. We want you to start going to the bathroom and then stick the cup under, fill it halfway, close it up, and be done. But we do need to make sure that clients are properly educated on how to do this. Go into the bathroom and wash your hands. Give them that moist towel. They have that moist towelettes, the cleaning wipe, and they need to cleanse their genital area. Men have it easy. They just have to clean the head of the penis. That's it. Rub it on. They're good to go. Women need to open up, spread, wipe it down. Take their container. They start voiding. Once they've got a good steady stream, put the container underneath, collect half full, close it. I always have them put it in a paper towel, but patients don't need to wear gloves. I mean, you guys have all done urine drug screens. I don't think they give you gloves to do this. You just wash your hands when you're done. But that's it. Making sure that it's midstream and that we clean beforehand. Let's see. I think that's it. All right, diagnostic procedures. So ultrasound is like the easiest exam for us to do because it's outside, it's not invasive. It can tell us what's going on with the kidneys. What's the size of the kidneys? Is there an obstruction? Is there a stone? Is there a cyst or a mass that's blocking things? Is there a tumor? They can see this through their imaging. So we definitely do a lot of renal ultrasounds or bladder ultrasounds, depending on where the area can be. X-ray, when we're doing imaging, that's that KUB, kidney, ureter, bladder. It will help us look for things like strictures or stones and see that something's not going properly, not where it's supposed to be, or having something we're not supposed to. The other thing, the CT scan, these are big. This will help us look for stones, the function of the kidneys, any type of masses. These can be with or without contrast. This will be dependent upon the function of the kidney, if they get contrast, and what specifically they're looking for. Patients that have kidney failure typically don't get contrast because their kidneys can't excrete it. It's stuck, and their kidneys are already damaged as it is. Honestly, the only time I've seen patients with, especially with end-stage renal disease, get a CT scan with contrast is when they're going to get dialysis right after, because then it can just flush it out. But we have to look at kidney function if they're getting a CT scan with contrast. Kidney biopsy, we can do these for any number of reasons. It's not just for cancer. Primarily, I mean, one of the big reasons is for that, but we can also, if they're concerned about organ rejection, if they've gotten a transplant, they can do a kidney biopsy. They put a little tiny needle in there, they pull out some tissue, and they'll run their tests. We do run the risk, though, of hemorrhage and infection because we have poked an organ and we've poked the skin. So assessing for those complications afterwards will be important. The MRI is another imaging technique that I know you guys are familiar with. In all honesty, in terms of the renal system, it's not something that's done a lot unless we're staging cancer. So they're trying to figure out how far it's spread. We have much other non-invasive, less radiation, less time consuming, less expensive tests. So really the only purpose of an MRI is cancer staging in this sense. All righty, cruising right along. So let's talk about kidney disease. So we're going to talk about acute kidney disease, chronic kidney disease, and polycystic kidney disease. So acute kidney disease, this can happen to anyone for any time. This happens when the kidney just suddenly stops working. The most common causes of an AKI, an acute kidney injury, is going to be a kidney stone, drugs, nephrotoxic drugs, infection, sepsis, heavy metal, or trauma. With an AKI, the kidney is going to recover. It will get better. So an AKI is not kidney failure. It just means that the kidney has a boo-boo, and it takes time for it to heal. So the 4 phases of a kidney injury is when it starts, that onset. That's when the injury actually happens. This phase will end when the oliguric stage starts. The oliguric stage of a kidney injury is when all of a sudden the kidney can't make enough urine. So we're going to have less than 400 mLs a day or less than 30 mLs an hour. So the kidney's been injured, and eventually within a day or two, the decreased urine is going to start. That's that oliguric phase. This phase lasts for about a week, 2 to 3 weeks. The diuresis stage is when the kidneys will start to recover. We're going to have an increase in urine output, and this lasts a little bit longer, 2 to 6 weeks for it to heal. And then the last stage is the recovery stage. This is when kidney function is fully restored, and this can take up to a year. So depending on the severity of the acute kidney injury, it could be a very short recovery, or it can be kind of a long one. It honestly just depends on the extent of the injury. Some risk factors for an AKI: volume depletion. So dehydration puts your kidneys at risk. Remember, all those jobs that the kidney did, if they're not getting enough fluid, the kidney's going to get damaged. If we're having issues with how the heart is pumping, how well it's working, that can lead to kidney issues. Those nephrotoxic drugs, they definitely can cause kidney injuries, and we'll start to see. And then infection. So it is extremely important that we treat infections quickly. What we'll see, fluid overload, because the kidneys aren't filtering, they're not getting rid of fluid the way that we're supposed to, so the body's going to be holding on to it. We can see that decreased urine output, that's at your oliguria. Some blood in the urine potentially as well. Electrolyte imbalances, because things are not shifting and transferring the way that they should, which in turn will lead to dysrhythmias. When the kidneys aren't functioning properly, we are at high risk for hyperkalemia. So, all right. With our AKIs, how we diagnose them: blood tests. We're going to look for that BUN and creatinine, which will be elevated. They'll do a urine analysis and they'll see a change in the specific gravity. And if they do an ABG, they're going to have metabolic acidosis because their buffering system is down. So that bicarb isn't being re-upped or recycled the way that it should, so it's going to be more acidic. Depending on how the injury occurred or what's going on will dictate the other type of imaging and things that are needed to be done. Okay, so there's not like a gold standard where like, yes, we're going to do this test. It truly depends on the mechanism of the injury. So that is very patient specific. But we can do ultrasound and X-ray and CT scans and biopsies and all that good stuff. When we have somebody with an AKI, monitor those blood signs, monitor those eyes and nose. We want to avoid nephrotoxic medications. And I know that's like, well, duh, their kidneys are hurt, but a lot of meds are nephrotoxic that we forget about. We want to, this gets delicate in terms of fluid restrictions, okay? 2 liters is a very common fluid restriction. Okay, if you look at the patients that you see at the hospital, like it'll say 2 liters, 1.5. So there will be a restriction on their intake. No smoking, maintaining a healthy weight, daily weights, because remember we can see weight changes when we're holding on to fluid. And if they have an infection, let's take those antibiotics, make sure that they're taking their meds. With AKI as well, again, they're going to be restricted on their electrolytes. We're going to see high potassium, high phos, low sodium, and high magnesium. The low sodium is dilutional if they're holding on to water. So we're going to be careful with what we're giving them and watching for dysrhythmias. So these patients probably should be on telly. Anytime the potassium is all wonky, we run the risk of those dysrhythmias. Other medications, IV fluids. But Amy, we're restricting their fluids. Yes, we are. But we also want to increase the perfusion to the kidneys, and we're going to be diuresing them. So we have to replace what we're taking off. It's like a gentle hydration. Okay. So we're going to be diuresing them, but we're also going to be giving them a little bit of fluid so they're not completely dry, which would cause more issues, right? So being able to recognize the symptoms of dehydration. What does dehydration look like assessment wise?
Or skin trigger.
Big one. Mm-hmm.
Low urine,
Urinating.
I'm sorry, low what?
urine output.
Okay.
Sunken eyes.
Yep. Pale mucous membranes. All signs that we would
Dry skin.
Oh yeah, it's gonna be very dry. Other meds that we're going to give, calcium channel blockers, especially if the injury was caused by a nephrotoxic drug. Calcium channel blockers stop calcium from getting into the cells. That's how they work. And if we're having issues with calcium, that medication will help them not be overloaded with the calcium. But we're giving them a blood pressure medication, so let's make sure we're watching their blood pressure. We also need to find ways to get rid of potassium. Sodium polystyrene, that's K-exolate. Anybody know what K-exolate is?
Isn't that like a laxative or something?
So it will flush out, but yeah, it'll make you poop a lot. The way that we get extra potassium out of the body is through feces. So this medication will flush you out and help reduce the calcium or the potassium in the body. So this is a medication you give before you go home for the rest of the day, so you don't have to deal with it. I'm just kidding, don't do that, but it makes them poop a lot to get that potassium out. Other things that we can do, and this is interesting, dextrose, insulin, and calcium. So if we have somebody whose potassium is like 6.5, is that high or low or normal?
Hi.
That's high. Normal calcium or potassium is 3.5 to 5. So anytime we're above 5, we run the risk of dysrhythmias. But when we have high potassium, one of the things that we can do is give insulin. Because remember, we learned insulin will lower potassium. They grab onto each other. But if our patient is not a diabetic and we're giving them insulin, or anybody insulin, their blood sugar is going to drop. That's an issue. So if we give them 10 units of IV regular insulin, we're also going to give them dextrose, an amp of D50, to raise their blood sugar. So the insulin won't work on lowering the blood sugar, but will grab that potassium. And then the calcium to help offset all that as well. We'll give calcium gluconate. So that's very interesting. And you'll see that a lot. Sodium bicarb will help with the metabolic acidosis. And then we have some phosphate binding drugs that we see a lot. I've seen a lot more with dialysis patients, but it grabs phosphate, free-flowing phosphate in the blood, binds to it and helps excrete it. They're big white pills, Renvela, but they can be on those temporarily as well. So a lot of different meds. Any questions about that? All righty. Now we're going to move on to chronic kidney disease. So I want to start off by saying chronic kidney disease is not end-stage kidney disease. End-stage renal disease is something else completely different. Well, it's not. It's like the end, okay? So chronic kidney disease has several stages. Where you are in a stage depends on how much of your kidney is still functioning. Kidneys are still functioning. So depending on what their GFR is, it'll tell us how well their kidneys are functioning. GFR is very interesting. It tells us a lot. There are racial differences with GFR. African Americans have different GFR averages than Caucasians or Native Americans. So we have the different stages of kidney disease. And a lot of times we don't catch it until like later on, like stages 2 or 3. So with stage 1, they have some kidney damage, but their kidney function is normal. You're really not going to see this too often. Stage 2 is when we're going to have a little bit of a loss. So the kidneys are working pretty well. No issues. We're not having any oliguria or anything like that. But when we get to stages 3A and 3B, we're going to start to see some changes. And these are our most common. So our kidneys are basically working at like 50%, which aren't great. And then
Amy,
stage 4, yeah.
what's like crazy about the CKD too, it's like it's irreversible, like it says on the PowerPoint. But what's crazy is when you go in like for a physical or to the doctor's office, sometimes they don't really put an emphasis on it. And I feel like it should be like a bigger deal than what it is sometimes in the doctor's offices.
Yeah, and it can take a long time for it to progress. So that might be the reason why, because most of us do not have kidneys that are functioning at 100%. They take the brunt of abuse between obesity, diabetes, hypertension. The more comorbidities you have, the worse off your kidneys are going to be. So for somebody who is maybe 25 years old and their kidney function is around like 90%, no, they're not worried. But if it was like 50%, well then most definitely. And anything can cause kidney disease, anything. Viruses, drugs, not just illegal drugs, genetic conditions. There's a lot. They take so much abuse.
I don't think people realize how much workout supplements do to your kidneys also. Because that's like because I donated a kidney to my dad, and that was like one thing. They're like, you cannot be on this for so like a certain amount of time before donating.
Yes, because there's so many different vitamins and other additives, and they're not FDA regulated. Yeah, they're very high in the kidneys, and so is a lot of protein. A lot of protein. When we get to like stage 4 is typically when they start talking about dialysis, maybe even 3B. It depends on it depends on the nephrologist. But stage 5 is what they call full on, like our kidneys are completely failed. And this is when we're getting to end stage kidney disease or end stage renal disease. I call it end stage renal disease. I'm sorry, that's just the verbiage I was taught and that's what I know, but it's the same. So end stage is when we have lost 90% function of those kidneys. That's significant, okay? So chronic kidney disease is different from end stage in the sense that chronic kidney disease still has functioning kidneys, pretty good amount for the most part. The less function you have, the closer you are to that end stage. Dialysis and transplant are really the only things that we have to help the kidneys, but they're not cures. So even patients that have had transplants, we're still watching the function. They're not going to have 100% function. That kidney might be working 100%, but they only have one. You really technically only need one, but yeah, we still have to be careful. So what we see with chronic kidney disease, those same symptoms that we saw with the AKI, so the decreased urine output, hypertension, that sort of thing, but it's widespread. We will see symptoms throughout the whole body, neurological changes, lethargy, decreased like mobility, The more diseases you have, the more likely you are to develop end stage. Some risk factors for chronic kidney disease. Acute kidney injury could lead to this, especially if it's not treated well. Diabetes, chronic glomerular nephritis. I have such a hard time saying that. Nephrotoxic meds like gentamicin can just destroy kidneys. High blood pressure, genetic conditions like lupus or polycystic kidney disease, or recurrent severe infections are some of those risk factors. The expected findings, again, look at that's every single system. And you guys don't have this one. I added this one in there because I didn't think what you guys had was enough. But lethargy, confusion, fluid overload, hypertension, dysrhythmias leading to heart failure, shortness of breath. There can be anemia because of that decreased erythropoietin production, skin changes, fragility in bones. That's every system can be affected by chronic kidney disease. Chronic kidney disease patients can be very sick kittens. Many can do well, but when it starts to go bad and get bad, it can be very, very bad. So testing for CKD, urine analysis, we would see hematuria, proteinuria, and a decrease in the specific gravity. We're going to see those changes in the BUN and creatinine. And then our electrolytes, decreased sodium because of it's dilutional. We have fluid overload, we're going to have low sodium. But then we're going to have increased calcium, potassium, phosphorus, and magnesium. And then we're also going to see a decreased H&H, a low hemoglobin and hematocrit. And this is because of the anemia, because of the decreased erythropoietin. So it all cycles back. Those kidneys are so important. Other things that we're going to do, KUB, CT scan. We can also do pilograms where we're going to take a look and see how the kidneys are functioning as well. But this is going to be a lifelong struggle with new changes to help preserve function. So the interventions, education, I's and O's, watching those vital signs. We're also going to have, these patients are going to be on fluid restrictions and they're not going to like it. But it's important that they understand the importance of fluid restrictions. Your body can't get rid of fluid as easily as somebody else with functioning kidneys. It's holding on to it. It's causing more issues. We have to control the amount of liquid that you're putting into your body because you can't get rid of it. We're also going to restrict potassium, sodium, phosphorus, and magnesium in their diet. A lot of times hospitals will call it a renal diet. That's what that encompasses. With CKD, we also reduce protein because they can't get rid of it properly and it can cause issues. However, the caveat to this is if the patient is on dialysis, then we increase the protein. So CKD, we would generally lower the amount. I don't want to say restrict, but we would watch the amount. It'd be a low amount, but if they're on dialysis, then we bump it up. We also want them on a moderate fat and high carbs, which is interesting. And then if they're diabetic, then it's a whole other circus. Then we work very closely with dietary. Skincare. We care very much about skincare. If we're running the risk of dehydration, decreased sensation. What is needed for wounds to heal? And I know we haven't talked about skin specifically, but you guys have had enough already.
Protein.
Protein?
Yeah. And if we don't have enough protein, we're going to have delayed wound healing. So it's a big mess. Wounds can take longer to heal. And if they're diabetic, forget about it. It can be catastrophic. So we really have to have great skincare. And I feel like giving medications goes without saying, but All right, medications for chronic kidney disease. Digoxin. Digoxin's a heart medication, is it not? Digoxin helps promote cardiac output. Remember, the kidneys and the heart go hand in hand. So if the heart is working well, the kidneys don't have that stress on them. That Kxalate, again, it helps with getting the potassium out by pooping a ton. So if they are going to the bathroom so much and having all these bowel movements, what would need to be assessed and what would you need to be cautious of?
Would this be like skin integrity or I don't know.
Skin integrity, sure. 100%. What else?
Electrolyte imbalance too.
Yes. And electrolyte imbalances can lead to what?
Arrhythmias.
Okay.
Neurological.
Mm-hmm.
Death.
She was. Yeah. So if we're worried about dehydration, we're worried about skin, we're worried about electrolytes, what else, what safety concern would you have?
Falling.
Up in blood pressure.
Yeah, they're gonna have to get up to go to the bathroom repeatedly, so they could potentially fall. So what safety precautions would we want to have in place? Teach them to use their call light, not having all 4 bed rails up, night lights or whatever to the bathroom, or the light on in the bathroom, whatever works. Anything to help promote safety that way. Grippy socks, right? But we do have to be concerned about falls. If we're giving medications that are going to cause people to go to the bathroom very frequently, and this one can dehydrate you, we have to be careful. Epoetin alpha. This is an injection that they get to stimulate RBCs. Because the erythropoietin isn't being produced, this drug mimics that and helps with that. So we can prevent anemia, which is additionally why we also give iron as well. Calcium carbonate helps with bonding to the phosphates. And then furosemide. We have to help. The furosemide can help. Kidney disease is very complex. All righty. Polycystic kidney disease. So PKD, we like our initials with the kidney. PKD is a congenital disease where fluid-filled sacs develop in the nephrons. Then that healthy tissue is replaced by these cysts, which make the nephrons not work and impairs the kidney function. This is most common in Caucasians. So this picture here, this is a normal kidney. They're not that big. For as big of a job they do, they are not that big. But these are polycystic kidneys. They are covered in cysts and extremely large and inflamed. So not pleasant. What we see with PKD is that family history, because it's a genetic component, abdominal pain or flank pain, and it's usually dull. If there's sharp pains, like stabbing pains, that usually means that one of the cysts have ruptured, or there's a kidney stone. We can also see constipation, bloody or cloudy urine, because look at those as they rupture. That stuff has got to get out somewhere. Nocturia, and then progressive kidney failure or kidney stones. We'll also have a larger abdominal girth, and we diagnose this through scans and watching our kidney function and UAs. The UA is just going to tell us what's in the urine. We can't obviously see that it's PKD. We need imaging for that. So with PKD, your goal with these patients is to control the blood pressure. This is extremely important. If we're not controlling blood pressure, the kidneys have to work harder. They look like that. So the hypertension can cause more pain and rupture of the cysts. Managing their pain. Give these people the drugs, guys. Okay, like give them the drugs. Preventing infection and constipation and education. Daily weights, watching our blood pressure, changing our diet. And then one other thing that they can do is they can have these therapeutic procedures where they'll aspirate some of the cysts, but the only cure for polycystic kidney disease is a transplant to get those diseased kidneys out. And normally with kidney transplants, they leave the old kidney in there. But with these, we're going to get those out.
The polycystic kidneys, is that usually bilateral?
Yeah.
Okay.
All right, so let's do our first polling question. I didn't like number 1. Here we go. Okay. Ooh, we got good participation. I'm at 72%. I'm excited. Ooh, 75. All right, I'm gonna wrap this up. 3, 2, 1. Oh, somebody snuck in there. 80%. Good job, guys. All right, so which patient should not be increasing their protein intake? That answer is going to be, well, first let's eliminate 2. We don't have to restrict protein with our AKIs. So those 2 are going to be out. So now we're down to 2 CKD, a CKD and an end stage. Which one are we going to choose? The correct answer is the 62-year-old male that's depleted 75% of his nephrons. He's not at end stage yet. It doesn't say that he's on dialysis. So those chronic kidney disease, we're going to restrict your protein, sorry. The 97-year-old is on dialysis. Dialysis, we increase. I have never seen a 97-year-old on dialysis, though. I'm just going to say that much. Okay. All righty, let's go ahead here and take a break before we get into, we're going to go into dialysis next. So let's go ahead. We are at 10:57. Let's come back at 11:10.
I've been reading books of old, the legends and the myths, Achilles and his gold, Achilles and his gifts, Spider-Man's control, and Batman with his fists. And clearly I don't see myself upon that list. But she said, where'd you wanna go? How much you wanna risk? I'm not looking for somebody with some superhuman gifts, some superhero, some fairy tale bliss, just something I can turn to, somebody I they told. The moon and its eclipse, and Superman unrolls the suit before he lives. But I'm not the kind of person that it fits. She said, where'd you wanna go? How much you wanna risk? I'm not looking for somebody with some superhuman gifts, some superhero, some fairy tale prince, just something I can turn to, somebody I can miss. I want something just like this. I want something just like this. Oh, I want something just like this. Oh, I want something just like this. Where'd you wanna go? How much you wanna risk? I'm looking for somebody with some superhuman gifts, some superhero, some fairy tale best, something I can turn to, somebody I can kiss. I want something just like this. Something just like this. Something just like this. Something just like this. Somewhere they're speaking, it's already coming in. Oh, and it's rising at the back of your mind. You never could get it unless you were fed it. And now you're here and you don't know why. But under skin knees and the skin marks past the places where you used to run. You howl and listen and wait for the echoes of angels that won't return. He's everything you want, he's everything you need, he's everything inside of you that you wish you could be. He says all the right things at exactly the right time, but he means nothing to you when you don't know why. Waiting for someone you to get over. Waiting for someone to push you away. There's always another wound to discover. There's always something more you wish he'd say. He's everything you want. He's everything you need. He's everything inside you that you wish you could be. He says all the right things at exactly the right time, but he means nothing to you when you island, into the highway, past the places where you might have turned. Never did notice that you still hide away, anger of angels who won't return. He's everything you want, he's everything you need, he's everything inside of you that you wish you could be. He says all the right things at exactly the right time, but he means nothing to you when you don't know why. I am everything you want, I am everything you need, I am everything inside of you that you wish you could be. I say It's the best thing that you ever had. The best thing you had is gone away. So don't leave me high. Don't leave me high. Don't leave me high. Don't leave me
Okie dokie. So reset up here. Got way too many PowerPoints open right now. All right, so dialysis. I want to preface this by saying that dialysis in and of itself is a specialty, okay? In terms of nursing, to be a dialysis nurse is different, okay? However, you will be caring for patients who go to dialysis or who have just went, and the things that you need to look for, and you also need to understand how it works. So we're not going to go over like the itty bitty specifics of like poking this and poking that or whatnot, but there's a lot of components to it. So dialysis in and of itself, there's three kinds. There's hemodialysis, which is probably the one you guys are most familiar with, peritoneal dialysis, and continuous renal replacement therapy, which is a specialized dialysis that's done in the ICU. So we touch on it very briefly. So what dialysis does is it will remove waste. It's going to pull stuff out of the blood and out of the body and get it out, because the kidneys can't do that on their own anymore. Dialysis typically begins around 80% nephron loss. Things that we also have to look out for is hyperkalemia, because they cannot filter out that potassium. And that is the most life-threatening component in regards to dialysis and not having it when patients don't go. Fluid overload, and just the need to remove toxins and waste. There are some patients who have gotten hemodialysis and their kidneys are fine, but because of what they've ingested or what they've went through, they need some dialysis to help them through. So we don't talk about rhabdo in this class, rhabdomyolysis, when we have breakdowns of things. But sometimes when the kidneys get so damaged, they need help. So they can temporarily be on dialysis for this. So they have to treat the hyponatremia and hyperkalemia. Yes, we treat it. The hyperkalemia typically gets resolved through the dialysis. And then the hyponatremia gets resolved more with diet, sodium intake that way. The goals of dialysis is to remove fluid and toxins. 1 liter is approximately 1 kilogram, which is 2.2 pounds. So taking off several liters, 3 liters of fluid, which is very common, is removing almost what, 7 pounds? That's a big weight change. That's why daily weights are so important. Dialysis done, we're going to talk about hemodialysis first. So hemodialysis needs an access, okay? We have 2 different kinds of, well, we have 3 different kinds of access points. The 2 common ones that are going to have this chronically are an AV fistula and an AV graft, okay? They are not the same thing. Any person that has a fistula or a graft You absolutely, positively, 100% need to assess that fistula or graft. You need to assess for a bruit and a thrill. Okay. The bruit is the noise that it makes when you listen to it, and the thrill is the vibration. It literally feels like a cell phone vibrating if you touch it. That means it's functioning. If it's not, we have issues. So this needs, if somebody has dialysis access, this needs to be part of your assessments before, after, during your shift. Okay. So the bruit sounds like this. Just a loud whooshing of blood. You could hear it if you put their fistula up to your ear, which is kind of weird. So we use our stethoscopes. But for patients, they should be able to do that depending on where it's located.
The one where you can feel the vibrating.
What was that?
Is that the one where you can like feel the vibrating? Okay.
That's the thrill. So somebody who has that, you want to touch it and you want to listen as part of your head to toe. If they have a fistula or graft, nothing can be done on that arm. We have a limb alert bracelet, however the facilities do it. We don't touch it. No blood draws, no blood pressures. Leave it alone. We want to protect our access point. Patients on hemodialysis will go to the dialysis center 3 times a week for about 5 hours a day, not counting transport time. They have to sit there for hours and hours while their blood gets filtered through a machine. So it's a big, big time. If the bruit and thrill are not there, we need to notify nephrology immediately, because that means we are probably clotted off and we can't use it. So, little breakdown here. We'll go over these a little bit more in depth.
What does a
Why are you talking? Okay. Tasha, I would say as part of your head to toe and after they come back from dialysis at minimum. So if you work a 12-hour shift, definitely with your head to toe. If they go to dialysis, when they come back, make sure you're assessing that as well. So the AV fistula is a connection between an artery and a vein. They kind of just like rewire things, okay? These are really common in the forearm, but they can also go in the upper arm or even the leg, depending on the access need. These are the gold standard. They're less expensive to maintain. However, they can take a while to mature. So they can fuse these vessels together to create this fistula. But they can't use it for dialysis because there's not enough pressure for dialysis yet until it matures. And this can take weeks, even months. They do have a very low infection rate, which is why they're used so often, and usually a lower association with mortality. So patients would come in, they'd get their AV fistula placed, they'd be in the hospital for 1 night, and then they'd go home. We do risk sorry. AV grafts also have a low infection rate. This is when they're going to take a tube, a synthetic tube, to connect the artery and the vein. They're often called loop grafts. It looks like a little loop, like a J loop we would use to put in an IV. That's what's used like to connect the artery and the vein inside their body. These are good for patients that have smaller or weak veins. They can be used a lot more quickly, typically, than a fistula, but they are more prone to clotting. So you'll never have to determine which one they're getting, but just understand that there is a difference. They are not the same. Both of these direct blood from the artery into the vein, which will increase the pressure and blood flow. And this will help with going through the dialysis machine. So usually what happens is these patients will have a catheter, a central line, a mahooker, they're typically called, right here in their chest. And that's where they'll do dialysis until their graft or their fistula is able to be used. We do not touch these dialysis lines that they have implanted in their skin. Leave them alone. We look for infection, but we don't touch it. We don't do blood draws. We don't do anything. They're capped off with sodium citrate. And if you were to push that solution into the body, it would not be good. So we leave them alone. Only dialysis nurses can tinker with them. They can pull stuff off of it, but we don't. Thank you, Angela. So yeah, if somebody only needs dialysis to get them through some kind of illness while their kidneys are healing, they're going to have the cuffed line. But if they need this because they're at the end and this is all they have to stay alive, they're going to have a fistula or a graft. So to kind of break down what happens here in dialysis, this is a wonderful video that explains the whole process.
Dialysis is a therapy that artificially removes wastes from the blood of patients whose kidneys can no longer perform this function adequately. There are two main types of dialysis, hemodialysis and peritoneal dialysis. In hemodialysis, blood is filtered outside the body in a dialysis machine. The patient's blood is pumped to the machine, cleansed, then returned to the body. To prepare for regular hemodialysis treatments, a one-time minor surgery is performed to create a vascular access, which is essentially a large and strong vein, enough to sustain the high flow rate through the machine. This can be accomplished by fusing an artery to a vein, forming a so-called fistula, or by adding a synthetic tube, a graft. For emergency treatment, a catheter can be used for temporary access. Once inside the machine, blood flows within tiny tubes surrounded by a dialysis solution called dialysate. The walls of the tubes act as semi-permeable membranes that allow only small molecules, such as water, nitrogenous wastes, and electrolytes, to pass through. The filtration occurs by osmosis and diffusion, where water and solutes move from higher to lower concentration. The dialysis fluid contains solutes at the levels similar to those in healthy blood. Urea, potassium, and other solutes that are present at higher levels in the patient's blood move out to the dialysate, which is constantly replaced and discarded. At the same time, other substances can be added to the dialysis fluid to be administered to the patient. These may include bicarbonate to adjust the patient's blood pH, erythropoietin to compensate for its low production by the failing kidneys, and certain medications. Because of the increased risks of blood clotting associated with its contact with foreign surfaces, an anticoagulant such as heparin is usually added. The composition of dialysis fluid is typically prescribed by a nephrologist based on the patient's needs. Hemodialysis is normally performed as 4-hour treatments 3 times a week in a dialysis center. Complications include risks of blood infection, thrombosis, and internal bleeding due to the added anticoagulant. In peritoneal dialysis, the dialysis fluid is introduced into the patient's abdominal cavity via a catheter. The lining of the abdomen, the peritoneum, serves as the natural filtering membrane. The fluid remains in the body for several hours, allowing exchange and equilibrium with the blood running in the underlying vessels before being discarded. The therapy can also be done automatically at night during sleep. Peritoneal dialysis is less effective than hemodialysis, but because it can be performed for longer periods of time, the result is comparable. Peritoneal dialysis offers more flexibility, is better tolerated by patients, and less expensive, but is more often complicated with abdominal infections.
Okay, so hopefully that helped break down hemodialysis a little bit and what happens. And it looks really small, but the dialysis machines are actually really big. I am not a dialysis nurse. I don't know that I could, but that's just me. Yeah, they stay in. Oftentimes they'll kind of take them down so they don't have that bruit anymore and that thrill. They're just like a lump sticking out of their arm. It kind of just depends, but any other questions I missed? Nope, that's good. All right, so post-dialysis, they come back to you from dialysis. You need to make sure you get a set of vitals. For the record, anytime a patient leaves the floor to go get a procedure done, no matter what it is, when they come back, get a set of vitals. All right. You also want to get a weight. They just had fluid removed. Okay. So you usually get a call from the dialysis nurse saying, okay, I had John Smith. He was on the machine for 4.5 hours. We took off 4.5 liters. His last blood pressure was this. Okay, that's really important information to have. So now we're going to get a new pressure, we're going to get a new weight, and we know what they actually did. So get those vitals, get that weight, take a look at their access site. Typically, they just put like a Band-Aid over the fistula. There's not a ton of bleeding, but we want to look at it, Brewie, thrill, and see if they are having any too much oozing. And make sure that they are just taking it easy. Educate them on the potential complications. You might feel tired. You might feel woozy. They know this. Dialysis takes a ton of energy out of you. Okay. These patients are not going to be like, oh yeah, let's go run a marathon or let's do this. They're going to want to sleep. We also need to make sure that they eat, because they don't eat when they're at dialysis. And that's for several hours. They take their medications. Many medications are held prior to dialysis because of how they're metabolized. So if we give them meds, some of them would just be completely filtered out through dialysis, which makes them ineffective. So we have to make sure we look at the meds before they go. What do they need when they come back to help with them?
Are they in PO before going to dialysis otherwise?
No, they eat their breakfast. Well, the goal, it depends on what time of day they go. But if they're scheduled for like 8 a.m., I want you to eat before you go, because I don't want you to poop out on them. But you can't eat while you're there. So let's make sure you have breakfast beforehand. I would just look at the meds to see if they're going to be filtered out beforehand. So that's the biggest thing.
How big are those needles that go into the vein and artery?
They're pretty big. They're pretty big. Yeah. The fistulas itself, I've seen some that are fairly small, like you can tell that they're there, and then I've seen big whoppers. It truly depends on the vascularity of each patient. But we do have to be careful with them. It's an artery. So if an injury occurs, you can imagine what happens. I had a patient once who came in one night, he had a fistula put in. So he was going to do a one night, we're going to watch, we're going to monitor, make sure we're good to go, and he was going to discharge in the morning. He had his kid with him who was under 18. That can't happen. The kid can't stay overnight in the hospital, but he had nowhere else to go. So the patient left AMA. Okay. Patient goes out to his car. He ends up like, I don't know how he fell or what he did, but he ended up hitting his brand new fistula and arterial blood all over the kid, all over the car, all over everything. That was, could you imagine the poor trauma of like a 10-year-old seeing all that? Like, yeah, super fun. So we have to maintain precautions and make sure that they're not going to injure that fistula. Other complications with hemodialysis, really it's going to be infection. So we're going to make sure we trust that the dialysis nurse are using aseptic technique when they're doing all this. They know what they're doing. But keeping bed sheets clean, that sort of thing, promoting good hygiene, hand washing, if there is an infection, giving them their antibiotics. So typically our dialysis patients, they have high blood pressure because the kidneys are failing, all right? So this is very common. Think kidney disease, high blood pressure. But when we're pulling that fluid off and we're filtering it off, we can tank their blood pressure. So we watch their blood pressure very carefully. when they're going through dialysis, their blood pressure cycles like every 15 minutes or every 30 minutes. I forget how often it is because I'm not a dialysis nurse, but they're looking at it frequently. If too much fluid gets pulled off, we can expect hypotension. So normally we treat low blood pressure for a normal person, someone without this condition, with fluids. Let's replace that volume. Kidney failure is a lot more delicate because they can't get rid of the fluids the way that somebody without kidney disease can. So they'll replace it gently, but they may also give midodrine, which is a medication that will help raise the blood pressure without giving fluids. So it's a delicate act. The way to prevent this is not pulling off too much fluid, which is beyond our control unless we're a dialysis nurse. Other complications, anemia. So they'll treat them with that alpha-poietin. But these patients are often coagulated during the process, right? So there's heparin in the diacylate to help prevent clots from forming. So we just want to watch for any type of issues with that. Typically there's not. If anything, they might have some oozing from the site, but we do want to make sure that we're looking for signs of anemia. Questions on hemodialysis? All righty. I'm trying to think if there's anything else I want to say there. I think that's it. All right. Peritoneal dialysis. This is another specialty. Okay, you can be trained on how to do this. Oops, slow down, Willie. We're not ready for Willie. So this occurs in the peritoneal cavity. A plastic catheter tube is surgically inserted into the abdomen. And what happens then is the patient is connected to a machine. It gets filled with a diacylate solution, and it'll fill and drain all night. It's going to pull waste products into that area. The peritoneal cavity acts as a semi-permeable membrane, and then it'll drain it out. So this is typically done at home. The worst part about this is having this catheter inserted, and at that point, well, after it's in, it's no big deal. So this is an example of a PD machine. These top parts where the bag goes, it has a warmer, so it's going to warm the solution. We don't warm the solution in a microwave, but cold solution can cause a lot of pain and discomfort. So we want to make sure that it's warmed on the machine. There's also a drain bag, which lays on the floor. This offers a lot more freedom because they don't have to go to a dialysis center how many times a week for all those hours. They do it when they're sleeping. So this hypertonic diacylate solution goes into the peritoneal cavity where it'll dwell. It'll just sit there for a while, pull, and then it'll drain. And it'll go through these cycles several times a night. Education is extremely important for this. These patients are at high risk for developing peritonitis. That's a direct entryway right into their peritoneal cavity. So aseptic technique is extremely important. Hand hygiene, like you wouldn't believe. PD is usually chosen because of the freedom. If they cannot handle anticoagulants that would be given during hemodialysis, if they have access issues, like we are not able to get a graft or fistula into them, those are usually it. And this is a decision that's made between the nephrologist and the patient and their families. My caveat to this, or not a caveat, my side note, only a nephrology attending can write prescriptions for dialysis. Not a fellow, not a resident, only the attending of nephrology. So a general practitioner cannot say, yeah, let's do this for hemodialysis, blah, blah, blah. No. we can potentially kill somebody. If you watch Grey's Anatomy, that happened. Izzy like killed a person because she gave the wrong prescription for dialysis and it like fried their brain. So only nephrologists. If somebody tries to say otherwise, say, well, we're going to talk to nephrology. That's their call. That's their job. That's their role. That's their specialty. It's like if you needed brain surgery, you're not going to go to, you know, a plastic surgeon. So that's my soapbox. I'm going to show you this little video. This is the cutest little couple, and walk through what PD looks like, because it's different than hemodialysis.
My name is Willie Tube, and this is my wife Alice Tube, and we reside in Baton Rouge, Louisiana. Seeing the PD treatment, I thought I liked it, the way it was performed, mainly because there wasn't no needles involved. And then with the PD, I got to go to sleep at night anyway, so they do the treatment at night, and when I wake up, I'm through with it. And she helped make the decision also. So she thought it would be a better idea to go through it also.
Because I knew he wasn't going to sit still. He's a very active person. And I didn't feel that would be the best thing for him. And I felt doing it at home would make him feel more comfortable.
Yeah, we see the doctor once a month and the reading once. The nurses there, they really take care of you. They really tell you what you need. They watch after you. They go through the list, telling you what you're not doing right and telling what you are doing right. And let's keep you going.
And I think we had a good training. She taught us everything we needed to know. And by the time we finished with the course, she said, I think you're ready.
And now it's ready for use. The bag will heat up for anywhere from 10 to 15 minutes.
Okay, it tells us to load our set.
We're careful to keep this together until we get it loose. We'll take this in and we'll place it here. It's already fixed.
Close the door.
Close the door, and I will place the one nozzle here, and we clamp off.
Push go. Connect this tube. I'm going to take this and put the clear side up on the floor.
Now I'll take my 3-minute wash for cleanness. We connect and I'll break the open this and open up the.
And it's primed. It'll prime for about 6 to 8 minutes.
Now we're going to open up the mini cap and connect. And when you connect, you don't want to stay open too long.
Okay, we've opened our cap ring and now we're ready to start.
That my sleeve to protect yourself. And black off here. And we'll block off here. Now I'm ready for the mini cap. Don't want to keep it open too long. You ready? All right, let's go. And that's it. I'm ready to go get breakfast. The machine goes through 6 cycles over the 8-hour period. And if I have to use the restroom or anything else, I can get up and the cycle continues to do its job. It doesn't bother me while I sleep. I don't feel anything. There's no pain. There's no congestion, anything. It just does its job. And when I awaken, it's finished. The dressing is clean and changed every day. You get used to it. It's just like it's not even there. The first few days you have it on, it's just like a normal procedure in your life that it's just there and it don't hurt, it don't irritate. She helped me very, very much. She kept me going.
It's no big deal for me. I love having him around. He's the love of my life.
They're so dang cute. So yeah, that's how the procedure goes. In the hospital, it's a little bit different. There's more masks and gloves involved. But PD patients, they know their routine and you cannot deviate from them at all. They get very, very particular because they're so prone to peritonitis. And if they've had it once, they don't want it again. And they'll tell you if you try to do something wrong. So again, as a new nurse, you wouldn't be doing something with PD. You get specially trained on the setup and the pins and the tapes and everything that goes along with it. Like just hearing the machine beeping was like triggering flashbacks to me because it's very loud. But it'll drain off into that drain bag that she put on the floor. And a yellow, it looks like urine will fill that bag up. And that's how it's done. One thing I forgot to mention with hemodialysis patients is they tend not to make urine, especially if they've been on dialysis for quite some time. So if you have a patient who's on dialysis, it is very helpful to ask them, do you still make urine? Because if they don't, you're not going to have output for them. But if you needed a urine sample, you're not going to get it. So if they don't give you urine, if they can't make urine, don't cast them, don't do anything. They're not making urine anymore. The machine does everything for them. Let's see here. What else about dialysis? So with PD, there's some things to look at. We may need to watch blood glucose levels, especially with our diabetics, because that diacylate does contain glucose. So something to keep in the back of our mind, like, hey, maybe. Looking at the color and the amount of fluid that's coming out, and then looking for any signs and symptoms of infection. The diacylate does need to be warmed, again, not in a microwave. And then we want to keep that output bag lower than the abdomen, like a Foley. It's okay for this one to be on a floor. Foley's no, PD solution, it's okay. When the fluid is being put into the peritoneal cavity, they may report a sensation of feeling full. That is okay. Feeling full is a normal finding. We're putting fluid into the cavity, right? Cramping and pain is not. That means something is wrong. Either the solution is wrong, it's too cold, there's too much, but if they're initially they'll say maybe I feel like a little full. That's all right. But then if it starts to impact their breathing and what's going on, then it becomes an issue. So the things that can go wrong with PD, peritonitis. We have to make sure that that area is properly cleaned. We maintain as much cleanliness as we possibly can. They'll report abdominal pain, fever, weakness. Their abdomen will hurt. It'll be tight. So they will need antibiotic treatments for this. Remember peritonitis? We've talked about it with the GI stuff and what can happen. It's that same infection. If the patient notices cloudy or like weird color waste in that bag, they need to let their nephrologist know. Peritonitis is the #1 complication of PD, and it's usually due to poor aseptic technique. So patients that don't necessarily have a great home life or live in an unclean environment or don't have good hygiene, this may not be the option for them. We also want to watch their protein. So looking at their albumin levels, they may need additional protein in their diet to help with this. If they're getting poor flow, we want to just look at, is their catheter kinked? It's a really, it's a rubber tube. It's really flexible, pliable. It can get pinched, just like an IV line. So is there any issues with that? We also want to prevent constipation. So everything's in the abdomen, right? Your intestines too. If you are FOS and you're trying to put this diacylate solution in there, it's going to cause too much increased pressure, or the proper amount of diacylate can't get into the peritoneum because your intestines are engorged with stool. So we want to prevent constipation with our PD patients to ensure proper draining and filling with this procedure. And then if they're having issues with breathing, again, they might have too much fluid in their peritoneum, so they might have to decrease that. These patients at home can do all these things on their own, but they just need to, they'll be taught. And a home nurse, a PD nurse comes into the home, they set everything up, their supplies are delivered, they're good to go. But they go through extensive training over some time to make sure that they can do this. And so are you, as if you have to do this at home or in the hospital. If you work on a floor, you would do this. All right, questions on PD? So they said PD is generally less expensive, probably because it's like done in a home setting and not a big, huge machine. Really what it comes down to, it's a conversation that's held between nephrology and the patient. Which do they prefer? Do they want this risk of doing things at home? Or do they want to do the 3 hours, 4 hours several times a week? So it really is a comparison based off of lifestyle and what they do. I know somebody who was in the Milwaukee Symphony Orchestra, and they did a lot of performing, and he needed to be on dialysis. He chose PD because if he was in a dialysis center 3 times a week, it would affect his job and his life. So really what it comes down to is life preferences. Insurance doesn't care either way from what I've seen, but I'm sure there's probably someone that would.
So the tube goes into the peritoneum, but does it go to a specific spot because you're taking fluid out and you're putting some in? Or is it just in the abdominal cavity somewhere?
Yeah, so it just goes into some location in the abdomen. They figure out where it goes, and the filling and the draining gets done from the same tube. So it's connected to a bag up here where the fluid is and the waste bag. So it'll fill the cavity and it knows when to stop, and then it'll kind of shut off and it'll sit in the abdomen for a while it works, and then it'll drain out the same tube, but instead of going it coming in, it's going out.
So it's the same fluid going in as going out.
Yes, but the stuff that's coming out will have all the waste products and going into a different bag.
So, but it's not going into like a ureter or blood or anything.
No, the peritoneal cavity acts as a permeable membrane. So the diacylate will pull stuff into it and then it'll drain it out once it's done. So the fluid will collect, it'll attract all the little stuff that it doesn't want, and it'll sit there, and then when it drains out, it'll all flush out. So it's acting like the kidneys would and just draining it out that tube versus all the urine. They might still make urine too, but.
Okay, it's coming.
Do they ever have to worry about getting up in the middle of the night?
Yeah, but those those tubes can be really long. Like, you know, they have a lot of room where they can get up and go. Or if you're a man, well, you got a urinal, you're good to go. So if they do need to disconnect, they can. It's just not recommended because then you're exposing it more times to air and risking infection more. So depending on mobility and how they are, a bedside commode might be a good intervention for them. All right. Great questions. Oh, yeah, okay. So CRRT. This is an ICU only dialysis. What happens with this? This is usually done with acute kidney injuries. They're super, super sick. They got exposed to some toxins or they're septic or something's going on. Something caused the kidneys to be like, I'm out. This machine acts as dialysis, but it's gentler because it's continuous. It goes round the clock. So these are one-to-one patients. There's one nurse for this patient. They're watching them specifically. So they're very, very, very sick. But this machine will filter out their blood around the clock. So it's like dialysis, but just a longer time frame. They'll use it through like the Mahooker point. They don't have fistulas, but yeah, that's about it for that. So this is a specialty. We just want to show you what it looks like. This is one of the bedside machines. A lot of tubes, a lot of filtration, a lot of buttons, a lot of things going on. If you see these, you know that the patient is not doing the best. Let's put it that way. All right, so now polling time question. And guess what? You cannot get this polling question wrong. It's your opinion. So. All right, so looks like most of you, a large amount of you said PD, and then the other ones were split between HD and the CRRT. So I really don't know what I would have to choose if that were up to me. I'd probably do PD, but again, like they said, it's not as effective because it still works, it's still effective, but hemodialysis is more effective. So it truly just depends on the patient, their comorbidities, and what they have at home and what they can, the resources that they have. Going to dialysis can be a lot in terms of transportation, the recovery, their support system. So
there is a sense of community though when you do hemodialysis, like amongst the nurses, the doctors, and the other patients. Like my dad, he thrived with hemodialysis, mostly because he was able to bond with other people going through the same thing.
Yeah, it's a lot. This is going to be a really poor comparison, and I'm sorry, but it's also like infusion clinics or like chemo centers or things like that where they're getting drugs because you're in the same room. It's literally a big room. There might be a curtain. But yeah, you get to know each other.
And they understand what you're going through because it's a lot. It's not, none of them are easy, but they understand like how you feel when you leave and your dietary restrictions, all of that.
It's definitely a built-in support system. And the nurses are very protective of their patients. All right, so let's go ahead. This is a good time to take a break because we're going to talk about transplants when we're done. So let's resume, what time? We're at 11:54, 12:05. Do, 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 do.
Don't you call him baby. We're not talking lately. Don't you call him what you used to call me. I confess, I can tell that you are at your best. I'm selfish, so I'm hating it. I noticed that there's a piece of you in how I dress. Take it as a compliment. Don't you call him baby. We're not talking lately. Don't you call him what you used to call me. I just miss your accent and your friends. Did you know I still talk to them? Does he take you walking around his parents' gallery? Don't you call him baby. We're not talking lately. Don't you call him what you used to call me. Don't you call him baby. We're not talking lately. Don't you call him what you used to call me. night. Moonlit wings reflect the stars that guide me through salvation. I stopped an old man along the way, hoping to find some old forgotten words or ancient melodies. He turned to me as if to say, hurry boy, it's waiting there for you. Gotta take the light to take me away from you. There's nothing that 100 men or more could ever do. I sense the rain down in Africa. It's gonna take some time to do the things we never The wild dogs cry out in the night as they grow restless, longing for some solitary company. I know that I must do what's right, sure as Kilimanjaro rises like Olympus above the Serengeti. I seem to cure what's deep inside, frightened of this thing that I've become. There's nothing that 100 men or more could ever do. I guess the rain's down in Africa. Gonna take some time to do the things we never Pretty voices waiting there for you. Gonna take the light to take me away from you. There's nothing that 100 men or more could ever do. I guess the rain's down in Africa. 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 Gonna take some time to do the things we never
Okie dokie, home stretch. Here we go. Let's see here. So a side note, not next week, the week after, we do the cumulative review in class. These really only work if I have content that I know you guys want to go over, okay? So what is the best way for you guys to communicate that to me? Should I do like a Microsoft form where you just type stuff in and send it to you, like post that, and you can just enter that stuff on there? I'm worried if you guys all send me emails, they'll get lost, and then I'll miss something, and then I'll feel like crap, and then I'll have anxiety and stress out. So
I like the Microsoft forms. They're easy.
okay, I think that might be it, because you know, some people also don't feel comfortable. They're afraid to ask, and if it's anonymous, then it doesn't matter. But I'm not gonna. I don't want to go over week by week by week by week and like redo content that way. But if there's certain things that were harder, I think that might be it. So I'm behind too. I have to post your guys's the diabetes stuff. There's not enough hours in the day. All right, so start thinking about stuff that you'll want to review, and then yes, there is a final key concept. I want to redo it. So you can look at it obviously and inform your opinion, but after I finish the stuff for this exam, the final is my focus, and I really want to redo the key concepts for the final. So I don't want to say don't use it, but I know that there's completed ones out there floating around, so there's that too. Okay. My mind is always like, burr, 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 burr. All right, we should be good. You guys can see kidney transplants. All right, this is my favorite. I love kidney transplants. They're my favorite patients to take care of right out of the OR too, because they don't go to the ICU usually. They go to the transplant floor. They're a lot of work, high acuity, but it's so awesome to see something happen, the change that happens within people. It's awesome. All right, so with transplants, they can come from several different ways. But kidney transplants are for those whose kidneys aren't working anymore or are dialysis dependent, meaning they're on dialysis, that they're at that end stage kidney, end stage renal disease, same thing. There are cases where patient hasn't started dialysis yet, but they're about to, but then a family member is like, oh, hey, I'll give you a kidney or something. So kidney donors can be living. The kidney can be living, like from a brother to a sister, a non-heart beating, meaning they're on life support, or a cadaver. We have a time frame where if the person died, we can use those kidneys. The best kidneys come with living related donors. Typically, parents are not good donors for children because they have stuff from both parents, but that doesn't mean that they can't or whatnot. It just truly depends on genetic lottery, in all honesty. But extensive blood testing is done with anyone. So when you're on the transplant list, you literally get a pager, just like in the movies and on TV. If you guys don't know what a pager is, go to TikTok, I don't know. But when an organ becomes available, potentially available, it goes off. And they come chuck into the hospital, they're like, hey, I'm here. And the worst is when it ends up not working out and you got to send them home. But they get checked in, they come to the unit, and we start the procedure. We start with blood. We take like 15 or 20 tubes of blood. We're looking at ABO, so your blood type. We're looking at antigens. We're looking at histo compatibility. Tons and tons of stuff is done to determine if it's a good match or not. And then if it is, we can get it going. But your role as a nurse, if you're working with organ donation, may be just you're taking care of somebody who had a transplant in the past or whatnot. This is another specialty. But there's some important factoids and you have to understand how kidney transplants work. So, why didn't that go? Please go, there we go. With kidney transplants, there's a lot of risks with any transplants. These patients are on lifelong immunosuppressant drugs. So this isn't like we're fixing it, we're giving you an organ, it's going to be great. There's a lot of follow-up, a lot of meds that have to be taken afterwards. So not everybody is a good candidate. The goal of organs and organ transplant is to go to the best possible candidate where it will do the most good for the longest amount of time. So those that are older than 70 aren't necessarily, they're at high risk for developing heart disease and cancers over somebody who's 30. So they're gonna outweigh things and they're gonna figure out if this is something that we can do. Or there may come a time somebody could be in their 40s and they say, you wouldn't survive this. You would not be a good candidate. So the role of working in transplant and determining people's status and where they are on the list and if they can get an organ, it's extremely stressful. You literally have people's lives in your hands and you can change them. So extensive interviews with patients in the support systems are done with transplants patients. They're going to look at their ability to follow up for these lifelong follow-up visits, their labs, and their ability to comply with the medication regimen and the testing and life that way. I think we talked about this with livers. There was that case where the guy was refused a heart transplant because he wouldn't get vaccinated. Vaccines are an important part of the transplant community because you're at risk for infection. We want to prevent them. It's not there to infringe on your right to medical freedom. We care about that organ and is it going to get the best life with where it is. It's why we don't give livers to alcoholics. We don't. They have to be sober for so long before they can get organ transplanted. We just want it to have the best and longest life and do the most good. So when it comes to the actual transplant, again, lifelong immunosuppression, lots of drugs. Jessica can probably speak to it too. There's a lot of medications that are involved with transplant afterwards. Some are forever, some are for short periods of time, but they're on drugs for the rest of their lives. If they don't take these drugs, rejection can happen, and then the organ can potentially end up being useless. So we have to make sure that they would follow up with something like this. So there's going to be mental health components evaluated and how things are going. So here you can see, this is where your kidneys normally lie. Up your upper back is where we can test that pain. When the kidney is transplanted though, it's like nestled like into the ileum. So it's not even at the same place, but everything is kind of like reconfigured and reworked. So more often than not, they will leave that kidney there because it still has the adrenal gland function and what's going on there. Unless there's a reason that they need to remove the diseased kidney, they leave it. I'm trying to think what else. Pretty much it. Oh.
You can feel the kidney too when it's placed there. Like I went to an appointment with my dad recently and the nephrologist was like, come feel your kidney inside of him. It was crazy.
Yeah. Did he get a kidney pillow?
I got one too. We both did.
Yeah. So a lot of the transplant programs, they give the donors and the recipients the organ that they received shaped pillow because we care about coughing and splinting. So they give it to you that's shaped like your organ. They're so cute. And then we always signed, the nurses always signed the pillow for the people. Not that I want one because I need an organ transplant, but they're so cute. Okay, so we're gonna get to meds, Lucinda, so hold that question. Let's see here. My clicking is not clicking today. All right, so before transplant, again, those labs, we're going to be doing, we're looking at your electrolytes, we're looking at, well, we're going to look at your kidney function, even though it's probably crap. We may or may not be able to do a urine culture. If they've been on dialysis for a long time, remember, they might not make urine. You're not going to get the urine. Don't cath them, okay? It's futile. It's risk for infection. It's not going to happen. Before the procedure, we typically also give pre-op antibiotics to prevent any infection and address any potential barriers. This isn't something that happens like in a day. This requires a lot of planning to go forth and to happen. So transplant medications. So med therapy is often surgeon specific and also dictated by insurance, because everything is. Some meds we look at blood levels, others we don't. So mycophenolate is an anti-rejection medication that's used in conjunction with other meds. So tacrolimus is a really common one. So they'd be on tacro and mycophenolate. We'd look at blood levels of the tacro. Everolimus is another one. They do the same thing. Again, it's going to be accessibility, cost, and insurance that's going to dictate, and the surgeon's preference. Certain nephrologists like certain things, and that's just the way that it is. Your goal is to recognize that tacrolimus, everolimus, and cyclosporin are all anti-rejection medications. They are lifelong. Because they are on these medications, their signs and symptoms of infection are going to be different. Their precautions are going to be different. We don't want them to get sick. They might have a fever of 99.9, which if you ask me as an ER nurse, that's not a fever because temperatures are average. But from somebody who's immunosuppressed, that could be significant. But we would miss it because, you know, well, poo-poo, it's not that bad. Maybe they went for a run, who knows? So other meds that we would do, antibiotics post-op to help with infections. Corticosteroids help with preventing rejections, but typically are not lifelong. They're like a couple months, weeks to months, depending on what's going on within the body. And then antivirals. Antivirals can be used to help prevent CMV infections, which can be catastrophic to immunosuppressant patients. However, renal function will dictate if and when this medication can be given, because it can be hard on the kidneys. And if we're replacing a kidney, it truly just depends on how well that kidney's working. So it is not uncommon to be on that for periods of time. They're also typically on PPIs to help protect that mucosal barrier and with acid production, especially post-op. Medications are expensive and often a barrier for patients. So beforehand, a lot of times programs will be set up for patients so they don't run out of meds or they have them delivered. So this is almost always set up before discharge to make sure that they have these access to meds, because if they don't take them, the organ can go into rejection. We'll get to rejection, because I think that has a scary connotation with it. So the teaching that you will be doing with transplant patients is significant. You work for hours with pharmacists and nurse and surgeons. It is truly collaborative. There's a lot of components involved. On a standard med-surg floor, somebody who's had a kidney transplant 5 years ago, you might see them. You'll see their meds and you can be like, oh, you had a transplant possibly, or tell me about it, you know, that sort of thing. Looking for signs and symptoms of infection or rejection will be primarily your goal. Fresh transplant patients, again, is going to be more of a specialty. So antibiotics are typically not long-term either, just for a few weeks after surgery to prevent those opportunistic infections and having major surgery as a whole as well. So after the transplant happens and they come back to you and you're so excited, can you guess what the number one thing, one of the number one things we're going to be looking at? Top things, fresh from surgery, with a newly functioning kidney.
Urine.
We're looking at those eyes and O's, baby. We care so much about urine, and I get so excited when I'm looking and I see that urine in the Foley for like the first time, or those levels going up and up. It's so exciting because these patients, a lot of them have not made urine, sometimes for years, and it's like, oh, welcome back. So urine output and their vital signs are going to be extremely important. When we do eyes and O's on fresh kidneys, we're doing them hourly. Okay, these patients typically aren't in the ICU unless they have another comorbidity going on either. So you're in there, you're looking at things every hour. Fluids, they're going to be getting a lot of fluids. IV, they're still going to be NPO after surgery, but they're going to get IV fluids, and we're going to watch the output. And watching, the urine is the sign that the kidney's working. We'll also look for bleeding, vital signs. What does hypovolemia look like? Low blood pressure, high heart rate, that sort of thing. And we will always be on the lookout for organ rejection. Immediately post-op, it's going to be a fever, high blood pressure, and pain at the site. And we're going to get more into rejection in a little bit. Watching for abdominal distension. Listening to bowel sounds to make sure that they're getting back to normal. Infection prevention will be extremely important. Hand hygiene, potentially even wearing masks, and well, everybody wears a mask now anyway. Gloves, that sort of thing, proper PPE, and dressing changes. Again, just be really excited about the P. So the big, bad, scary things that can go wrong. Organ rejection. So I want to preface this is just because somebody goes into rejection doesn't mean we can't fix it. Sometimes we can. Sometimes it does mean that the kidney is just not going to work. We have to go back on the transplant list. It wasn't a good match. But so we can fix rejection sometimes. It truly depends on where it's at, the symptoms that are happening, and what's going on. So hyperacute rejection is within 48 hours of transplant, and that's going to be that fever, high blood pressure, and pain at the site. Let's say they're discharged. Everything's going fine. But then when they're at home, they have to know what the symptoms of rejection are at that point, which is going to be decreased urine output or no urine output, which is anuria, a fever, lethargy, holding on to fluids. We're not functioning properly. We have to fix that. So we assess organ rejection. They'll do a kidney biopsy to see what's going on. And then there's chronic organ rejection, which happens gradually over months, even up to years afterwards. So they'll have impaired kidney function, electrolyte imbalances, and fatigue. So we have to always be concerned. One of the biggest reasons why organs get rejected is medications, compliance with medications, or maybe it's the wrong medications. And then sometimes it truly, the organ just doesn't work, which is unfortunate. We see that more with cadaver kidneys, where it just does not work as well as we want it to. And that's why the living donor is so great. Infection is the most common cause for death after transplant, and it's because of those different signs and symptoms, and sometimes they're more innocuous, and it makes it difficult. Infection prevention is going to be key. And just because they had a kidney transplant 5 years ago does not mean that we still don't, that their risk is any lower for infection, if that makes sense. So afterwards, education, education, education. Patients and their families need to understand what rejection will look like, what their meds are, what times they take them, what they're for, what their doses are, what they look like, their diet, activity, signs and symptoms of the rejection and infection, and then their importance with follow-up and setting up follow appointments before they even leave, or what's going on. But again, pharmacists, case managers, surgeons, nephrology, nurses, dietary, they all work in collaboration. There's a lot of people in and out of those rooms. PT, OT. I'm trying to think if I'm missing anything. I think that's it. It's been a minute. Jessica, if you don't mind me asking, when your dad was discharged, did he get a pretty little card with stickers and when to do meds and what they looked like? Or was
That's kind of a blur because I was on pain meds, but I know for like a couple of years he had a binder that he filled out every day, like weights, temperatures, and like when he like the times he took his meds. But we also set an alarm on his phone, so it's 8 p.m. and 8 a.m. every day.
Yeah, because timing will be important too. With our transplant patients, they did get a binder with med sheets for everything. This is all about mycophenolate. This is all about Prograf. This is all about this. But we gave them a little card that had a picture of the med and then what times they would take it and what their doses were. And then, yeah, all their follow-up stuff and tracking, and a lot goes into it. And it's not, unfortunately, it's not one of those things where you get the kidney, you're good to go.
I don't remember that. We weren't, I mean, my parents don't live by the hospital, so his was done at U of U Health, and they live in Boise. So we were here for a while. They were here for like 5 weeks. And, you know, you're in there every single day for what, the first 2 or 3 weeks, and then every other day. So they were constantly at the hospital doing blood work.
Yep.
And at appointments.
So you can see why potentially people can fall off, because if they don't follow up or they miss one, it puts them at high risk. It is a lot. It's a lifestyle change, especially those first few months. And people that donate kidneys, you know, they come out of surgery, they have their Foley, they're typically discharged in 2 to 3 days. Once we know that their kidneys are functioning, they're making urine, their pain is improved, they're ambulating, they're eating.
At U of U, they'll discharge you the next day if you feel good.
Yeah, I think the longest I had somebody was 2 days. That's because they spiked a fever. We want you gone. I'm just kidding. If you donate a kidney, okay, and something happens and you end up needing a kidney, it does propel you up the list. So if that's ever a doubt in your mind, like, oh, I would never give a kidney because what if I need it? It's kind of like a hall pass, like skip to the front type thing, because yeah. All right, let's do a poll question.
Isn't the quality of life typically better in organ donors because they're more, or they're supposed to get their regular checkups, their regular blood work, so a lot of undetected diseases get detected early?
I never thought about that, but that completely makes a lot of sense.
That's what they told me when I was doing the testing, because I mean, because you're supposed to be compliant with your regular physicals, your regular blood work, and typically they live healthier, longer lives because things are monitored.
Yeah, that makes a lot of sense. All right. Oh, a couple more. All right, so single most common cause of death is going to be that infection because of the immunosuppressants. An infection will present not as obviously. Share. Okay. Questions on transplant? All right, so now we're going to talk about infections. I'm hoping this is kind of easy peasy for you guys because we know UTIs, right? So UTIs are infections of the lower urinary tract. So usually, you know, your urethra and your bladder. The risk factors, being female. I'm sorry, but urethras are shorter in women, so it's less place for or shorter distance for bacteria to get into the bladder and wreak havoc. Also having a catheter, any type of stool incontinence puts you at risk for a UTI. Most common bacteria for UTIs is E. coli from the stool, as well as wearing briefs. I want to make sure you guys understand they're talking about briefs like Depends or like adult diapers, not brief cut underwear. Okay, they're talking about briefs. Okay, Ashley's laughing at me, but you know, it's true. So with a UTI, about half of them don't have symptoms, which is unfortunate. But if they do, typically they'll present themselves as some lower back pain, which we almost always poo-poo because like who doesn't have back pain? But there can also be some of that flank pain, so on your sides. The dead giveaways are going to be the burning with urination and that frequency and urgency. So when you have a UTI, you go to the bathroom, you're like, oh my God, I have to pee, I have to pee, I have to pee. You go to the bathroom and like 4 drops come out. And then you are like, okay, well that sucked. And then you have to go back like a few minutes later. Like you just constantly are going through this battle, like I have this going on. Burning upon urination can also be indicative of a sexually transmitted infection. So we have to, when we are assessing for UTIs, we're also assessing for those as well. Other expected findings with UTIs, cloudy or foul smelling odor. Urine should not be foul smelling. If it is, there's probably bacteria present, all right? And you should be able to see through urine. It shouldn't have an opaqueness to it. With older adults, they present a little bit differently. If you have had the sweetest little old lady, she's been so nice to you, she's just doing the most wonderful things, she's great, and all of a sudden she turns batshit crazy, like totally off the wall, like doesn't make any sense, maybe combative, but doesn't have dementia, check for a UTI. If you have a personality change in an older person, male or female, check a urine, because the biggest culprit is going to be a UTI.
Well, and that was so weird because when I used to work as a CNA in a long-term care facility, they would be acting so strange, and we're like, is it Alzheimer's? Like, is it dementia? And then the DON, she's like, no, we just need to get a UA. And I was like, that's so crazy.
It completely transformed their personality. So you can have the sweetest old lady, and then all of a sudden she's like a WWE wrestler or something. Like it's crazy. And again, men or female. And it's easy to get a urine. However, if they're going to be combative and we need to cap them for it, then that's a whole different can of worms. But if you have a personality change like that, check the urine. Also with the older adults, we'll see more vital sign changes, lower blood pressure, heart rate, higher respiration, and fever. All those signs and symptoms are symptoms of sepsis. And urosepsis is like a urinary associated sepsis. You may or may not hear that terminology anymore, okay? But a UTI can absolutely turn into sepsis, which is catastrophic. So, CAUTI prevention. CAUTI is a catheter-acquired urinary tract infection. We don't want these. If your patient has a catheter, our goal is to prevent them from happening. If your patient develops a UTI while having a catheter under your care, insurance ain't paying for it. It can lead to a whole bunch of other issues. So prevention is key. The number one thing that we can do, well, not number one, but one of the biggest things that we can do is make sure that a catheter is not in longer than it needs to be. Catheters are not meant to be convenient. Okay, yes, they have a purpose, but if they're incontinent, that's not a reason for a catheter. It's not. Usually they're post-op or during surgery or for strict eyes and O's because they are so deathly ill. Other ways to prevent infection is going to make sure that the catheter can flow freely, like the urine is not, the tubing isn't kinked or anything. That the bag is below the bladder, but not on the floor. Emptying the bag frequently, at least every 8 hours. And good technique when it's being entered. So when you're putting in a Foley, I think a good rule of thumb is take 2 kits and 2 things of sterile gloves. Why? The sterile gloves and the kits never fit my hands. That's one. But if you're putting it into a woman and you put it in the wrong hole, and you will at least once, leave it in, and you got a whole other kit to go ahead and get it in the right one. Okay. But making sure that we're cleaning. Grab assistance. You might need help with holding labias back or holding up a fupa. You might, because all that stuff can cause issues with the insertion. We want to use the smallest catheter possible. If we cannot get the catheter in, maybe there's an obstruction or a stricture or the prostate is being an issue, don't force it. Urology is there for a reason. With men, if they have issues with prostates, we use a Coudet catheter, and it's a little bit, it has like a curved tip and it's firm. So when it goes in, it can get underneath that prostate and get to the bladder. Whereas a normal catheter has that flimsy head and it'll just hit the prostate and nothing will get through. Is UTI risk higher with a catheter or briefs? I'm gonna say, oh God, I don't want to say. So catheters are high risk of infection, but so are briefs. But catheters are like, think of it as like a ladder. It's a portal of entry. So that's why I would say it's more, but just a little bit more. Bacteria will climb up that catheter and get to where it needs to be. Whereas if they're wearing briefs, they still have to get into the urethra and travel its way up. They both suck. It is important with catheters that you wash the perineal area with mild unscented soap at least twice a day. Pericare needs to be done typically more than that, but at bare minimum twice a day. All right. Anything less than that puts you at risk for developing a UTI. Anything else? The big stuff is highlighted in red, but they're all equally important. All right. To diagnose a UTI, we're going to do a urine analysis. So we're going to pull some urine off. If they don't have a catheter, we're going to do that midstream collection. If they can't provide one, then potentially we could do a straight cath. Or if they have a Foley, we can grab a sample off of their Foley. It's important if you're pulling it off a Foley that you do it properly. So once you empty a bag, like you unclip it and you open it up to empty out the urine bag, that seal's been broken. So any urine in there is no good for urine analysis. We would have to pull it off of a port up at the higher point of the insertion point. There's little lure locks where we can pinch and pull urine off of. That's the urine that we would want. If I put a brand new Foley into somebody and then I immediately got that return and I never opened the bag, then I could use it. But for the most part, just use the port, grab the urine from there. If there's bacteria present, then they'll do that culture to figure out what antibiotics that it's susceptible to. Typically with UTIs, there'll be bacteria present, some sediment, which looks like almost granules of sand, sometimes some clumps, even blood. And then again, they'll also do that STI testing to rule out that as well, because They can go hand in hand. Not everybody that has a UTI has a sexually transmitted infection, but we want to make sure that they're not hand in hand. Okay. Let's see here. Interventions. Let's chit chat. So, do they need the catheter? If they don't, let's get rid of it. Potential complications, kidney issues, sepsis, septic shock, pyelonephritis. If we don't treat a UTI, pyelonephritis can occur, which is an infection of the kidneys. 100%, it is a real thing. If pyelonephritis happens, and can happen pretty quickly, that can lead to kidney issues and sepsis and death. You can die from a UTI. Ooh, that rhymed. Medications will be important. Antibiotics, making sure that they're getting the same, they're taking all their meds, completing the course, and pushing fluids, and education. Remember, common sense is not so common. All right, we have to educate. So, because females are more susceptible, this is geared towards females. Wiping from front to back. You would be amazed at the amount of people that don't wipe properly. This is one of those teaching points. If there is a UTI, we do treat it pretty aggressively in pregnancy. Yes, I know this is not an OB class, but UTIs can be damaging to the baby. So recognizing those symptoms. We also teach to avoid bubble baths. But bathing is good. Why would we avoid bubble baths?
Bacteria in your bath water. And is it because of like the certain soaps that they use too can cause bacteria?
Yeah, they can increase irritation. The scented stuff causes an increase in pH, can cause vaginal dryness. You itch, you scratch, you break a membrane, boom, you're at risk for infection. We avoid anything scented. One thing I always tell my patients, the vagina is a self-cleaning organ. It takes care of itself. Stop sticking scented stuff up your hoo-ha. Let it do its job. It's supposed to produce the right amount of discharge. It shouldn't be foul odoring. It does its own thing. When we add these scented products, it's changing the pH and it's changing the way that it's supposed to be and causes more problems. Just let it go. It's not supposed to smell like peonies and roses. The other thing that I think people are very guilty of, and I mean, everybody's guilty of it, is a wet bathing suit. Okay, you go to the beach for the day or you go to the pool and you just lay around. Trapping moisture in that area, bacteria likes it where it's dark and warm, and that is just a breeding ground for bacteria. So those wet bathing suits can be an issue. That's really, I think, the biggest problem with little girls that tends to be an issue. And, you know, we wear breathing suits all day in the summer sometimes, so.
Workout clothes also cause that.
What was that?
Workout clothes.
Yes. The wrong type of breathing and stuff like that. We have to let things breathe. Everyone should urinate after intercourse. Let's flush that stuff out, get it out. We don't want it. The lubricants, the oils, the semen, everything, get it out. So we always want people to void after intercourse. Wearing cotton underwear. I know they cannot be the cutest, but certain types of fabric trap moisture, trap bacteria based off of how they are. And if they're really too tight, wearing tight clothing can also impact the ability for things to breathe, not just with women, but with men too. Making sure that we're urinating every 3 to 4 hours. Again, you are not a baddie if you're like, oh yeah, I only peed once today. That's just dumb. Let's prevent urinary tract infections. We want to promote good renal health, urinary tract health, that sort of thing. And staying clean. So good hygiene. We don't want to use scented products. And then if you think about like what you use in the shower, like, is it safe? Or do you have a separate product that's like a non-scented to let it clean itself? Or, you know, yeah, our Bath and Body Works body wash really should not be used down to the JJ. In terms of diet, fluid. We want to push fluids. We should be consuming at least 3 liters of fluid a day. Good fluid, water, teas without caffeine. Well, not even teas. Teas can be irritating if they have caffeine in them. Cranberry juice. Guys, there is a difference between cranberry juice and cranberry cocktail. Okay. One of them cocktail has a lot more sugar in it. Sugar is damaging. So not all cranberry stuff is created the same. Look at the amount of added sugar in there because that's not what we want. All right. Coffee and spices, booze, cola, that can all irritate the urinary tract as well. So we tend to avoid those when there's issues. Some people will take cranberry supplements to help with that. Cranberries have anti-inflammatory properties that can help. But again, not for everyone. It truly depends on the person and their makeup, genetic makeup, not the stuff on your face. There are some over-the-counter products that we were kind of talking about earlier, like the Azo. Do they work? I'm going to refrain from commenting. That's truly person dependent too. But go to the bathroom, drink your water, keep your genitals clean. There we go. All right. Poll question. Oops, I never stopped sharing that one. Let's see if you guys remember your UTI teaching. Ooh, that cruised right along. Okay, so what teaching would we want to include? 100%, oops, drink 3 liters of fluid a day. We don't wipe from back to front, we wipe from front to back. We want you to wear cotton underwear, and teas can be an irritant to flushing out for the system. So, all right, questions on UTIs? All right, I gotta take it into gear. Pyelonephritis. The #1 cause of pyelonephritis is E. coli and repeated infections. This causes scarring, which can disturb the blood flow. Pyelonephritis is infection and inflammation of the kidney and all its components. This is very common in females aged 20 to 30 because we tend to ignore everything and we think everything's going to be fine, but it's not. So again, this is caused by a bacterial infection that has not been treated, or a very, very aggressive one that came on very quickly. Repeated infections can cause damage to the kidneys. So this is something that we want to prevent from happening. Other risk factors: men over 65 with prostate issues, chronic kidney stones, spinal cord injuries, pregnancy, diabetes, not emptying our bladder fully. It will present itself with abdominal pain, flank pain, or that costovertebral angle. So in the back, create that V, there'll be pain with palpation. Also be some nausea, vomiting, fever, chills, rigors, high blood pressure, bacteremia. We have an infection in the blood. This is a serious, serious infection. This is why we treat UTIs quickly. This is very painful and can lead to death. So all teenage girls need this lecture because they're like the biggest culprits. So with pyelo, I's and O's, shocker guys, right? We're talking about the renal system, watching their electrolytes, watching their vital signs and their pain, looking for signs and symptoms of sepsis, that low blood pressure, high heart rate, lethargy. We diagnose sepsis through blood cultures and inflammatory markers. And we're also going to do urine collections as well. Important education factoids or points, nutrition and fluids. Okay, we want them to be drinking. We want to help flush out those kidneys. Medications are going to be anti-fever meds, pain medication, and antibiotics because it's an infection. Depending on how severe the pyelo is, it could be anywhere from up to 2 weeks or even IV medications if it's really, really bad. And if it's really bad too, they could probably be in the ICU on some vasopressors to help raise their blood pressure, which happened to a friend of mine not that long ago. Other things that they can do, if the pyelo is caused by an obstruction or some other issue like a kidney stone, they can surgically remove the kidney or the stone. If the kidney itself is diseased, infected, and causing issues and just dead, they can remove the kidney. That's a nephrectomy. Or if there's something wrong with the ureter, they can revise it. They can rework things to preserve function. Because if the ureter sometimes gets damaged, that can cause issues with the kidney itself as well because of backflow. All right. I hate saying this next one. Glomerular nephritis. I have such a hard time with this. This is any disorder that causes glomerular injury. Okay, so the nephritis, it can be caused by infection. It could be caused by exposure to a new bug from traveling, other diseases. Anything that causes damage to the glomeruli is glomerulonephritis. So there's not like one single cause or one single bacteria. It's a blanket term for damage to the glomerula. With glomerulonephritis, there's nausea, fatigue, high blood pressure, but with glomerular nephritis only, we have cola-colored urine because the glomeruli have been damaged. So cola-colored urine, think about the glomeruli. There we go. To diagnose this, we're going to do a UA where we will have red blood cells and protein present in the urine, which we shouldn't. Their GFR is going to be low because they're damaged. They can't function the way that they're supposed to. We can also do a 24-hour urine and check out products in the urine. We'll also look at their labs, their kidney function, and their electrolytes. This can also be diagnosed by a kidney biopsy. In terms of treatment and nursing interventions, you know, we're always talking about like staying active and whatnot. With glomerulonephritis, we tend to want them to kind of conserve their energy and just kind of relax. And we potentially will restrict their fluids. Their kidneys are not going to be functioning as well, so we don't want to overload them. Looking at their blood pressure, looking at their fluid and electrolytes, and then any type of medications. Antihypertensive are very common because their kidneys are not working that great and they need an assist. So this can be treated. Okay. Then we have nephrotic syndrome. Nephrotic syndrome is different. This is any condition that seriously damages that glomerular membrane, and then we have increased proteins. Okay, so the barrier, the membrane that was there, prevents proteins from getting in. With nephrotic syndrome, that barrier has been damaged, so it's kind of like a free-for-all. So what we will see with this is massive proteinuria, but a decrease in albumin in the blood, hypoalbuminemia, and edema, diffuse edema all over, including the face. They will also have high cholesterol. The most common causes of nephrotic syndrome are going to be diabetes, lupus, multiple myeloma, and glomerulonephritis that has just not been taken care of or not been treated well. So that could lead to this. It's not disease specific, but a group of clinical findings that result from glomerular damage. So we treat it like we would somebody with glomerulonephritis, all the way to end-stage renal disease, depending on what's going on. We want to prevent that from happening. So the goal is to treat the underlying cause if we can, and to slow the progression of the kidney disease, and then give medications. ACE inhibitors are one of the drugs that we give because they're actually really kidney friendly. They help with the kidneys a lot. And we want to reduce the cholesterol. So nephrotic syndrome, lots and lots of protein in the urine, hypoalbuminemia, and diffuse edema. Diffuse meaning all over the body. Alrighty. This one gave students a little trickery yesterday. Let's see if you guys are smarter. That's not right to say. I'm sorry. All right, so what unique symptoms sets nephrotic syndrome apart? Tricky. So nephrotic syndrome has the hypoalbuminemia. Glomerulonephritis has the cola-colored urine. So just a quick little review, kind of like a weird breakdown of how things can lead to one another. So UTI, glomerulonephritis, they're not the same, okay? They're in the same category though. They can start off as this. They can lead to pyelonephritis. UTI can lead to pyelonephritis. Glomerulonephritis can lead to nephrotic syndrome. Left untreated or not treated quickly enough or not treated correctly, that can lead to an acute kidney injury. And then worst case, chronic kidney disease or end-stage kidney/renal disease. I have to look. I don't know if your book calls it ESRD or ESKD. I've never heard of end-stage kidney disease. It's always been renal, but that's just me. It's bugging me. All right, let's dive into kidney stones. Renal calculi, also known as urolithiasis. I cannot say that, so I will say kidney stones. But you need to be able to recognize that that word means kidney stones. We have stones in the urinary tract. Most clients, not actually, I'm gonna back up. There are many different causes for kidney stones, okay? Sometimes it can be your body does not metabolize calcium the right way, and we have calcium stones. Or we have too much ammonia, and then we have struvite stones, or we have uric acid buildup, and we have uric stones. There can be any number of reasons that causes a kidney stones. Some people are just prone to them. Typically, patients can get rid of or expel the stones without invasive procedures. They pee them out. We give you fluids, we give you Flomax, we dilate, we let it come out. However, what the stone is made of, how big it is, and where it is can determine if the stone can be passed or not. If it can't, then we have other measures that we can take. You guys probably all know somebody who has had a kidney stone or have had them yourself, unfortunately. They're not fun, from what I hear or see.
I think that they're worse than labor, personally.
I have heard that as well, but almost exclusively from men. So I tend to, you can't compare the two from a man, but yeah, they cause a lot of pain for being so small. And we measure them in millimeters. This is an extreme case in the bladder, like that's a lot of stones. That's something else completely, but these little guys can be all over. Risk factors for kidney stones: being a male, not urinating enough, excuse me, or having concentrated urine, or having some metabolism issues with calcium oxide or purines. Those are the those three types of stones. When somebody has a kidney stone, they will have severe pain in either their flank, which means the stone is in their kidney or their ureter, or their abdomen or genitals, which means it's in the ureter or bladder and like on its way out. So we can kind of tell where the pain is, where the stone is based off of their pain, in theory. Usually it's pretty diffuse. They will also have fever, nausea, vomiting, and blood in their urine. Nephrolithosis are stones in the kidney. That means the stone is still living in the kidney. Uretolithosis means the stone's in the ureter. That pain is often described as wave-like and excruciating. Your ureter is a very small tube. These stones are bigger than the tube. It can cause blockages, and as it's moving along, it's going to be just dragging itself along that teeny tiny little tube. So yes, it is painful. Give them all the drugs. To diagnose a kidney stone, good old KUB. This is an example of a KUB, kidney, ureter, bladder. See, we can see a lot. This is an example of a stone. This is what we call a staghorn stone. Stones have shapes. Staghorns, who knows what a stag is? Nobody yesterday could tell me what a stag is. You guys are from Utah, please
A
tell
horse?
me. No.
Or is it a deer?
A male deer. You've seen Harry Potter. They have the antlers. So the staghorn has little horns on the stone. That's where they get its name from. And if you're trying to pass that can like rip and tear and cause issues. So that's a pretty big stone that you can see visually. An intravenous pyelogram is where they're going to put something through your veins to kind of light things up, but it's not contrast. We don't use contrast with kidney stones because if there's a blockage, we can damage the kidneys. Or they can do a renal ultrasound to see things as well. So we can diagnose kidney stones any number of ways. Usually we can diagnose a kidney stone just based off of their symptoms. Like they'll be holding their back, they'll be gagging, nauseated, in extreme pain. And if they're a male, we can almost guarantee that it's a kidney stone, but we need to know where it's located. So we would do some imaging to kind of see where we're at, how many, how big, because that's going to dictate our plan of care. The medications, pain medication, pain medication, pain medication, also giving them fluids. They can also be given some antispasmodics to kind of help with the passing of the stone. Flomax, that's an alpha blocker. That will help with increasing the vasculature so we can pass the stone a little bit easier. Eyes and O's. All urine should be strained. So what we typically do is we have them void into a hat or a urinal, and then we pour it through a strainer over the toilet. And that way we can see if the stone passed or not. But all urine should be strained. We're also going to want to push fluids. And this is a hard one. We want you to walk. They're going to be mad at you. They're going to fight you. They're not going to want to. They're in so much pain. But we want the walking to help with the passing of the stone. Things that we need to look out for: infection. So we're going to be watching that urinary, watching a UA, especially if it's a long term. People typically with kidney stones come to the ER. They get their drugs, they get their strainer. They may or may not pass it while they're there, but they go home. Sometimes they are hospitalized for these though, depending on what's going on. We have to look for obstruction. if they're not able to produce urine, the urine is going to go backwards and cause hydronephrosis, which is going to be swelling of the kidney. We don't want that to happen. So they're not passing it on their own, or it's a big daddy. What can we do? So the extracorporeal shockwave lithotripsy. This is the most common procedure used for kidney stones. They use sound or a laser, some kind of shock wave to break up the calculi into little tiny pieces so it can pass. This requires some conscious sedation. So you have to think about, okay, they got some Versed, what am I assessing for? And the patient also needs to be educated that there can be some bleeding or some bloody urine afterwards. Stenting is when they place a small tube into the ureter to dilate the ureter to allow the passage of the stone. This is very common as well. And then a retrograde ureteroscopy uses a forceps of some kind to go into the ureter and grab the stone. I'm sorry, that sounds really painful because the ureter is not that big. Open surgery may be required if the stone is extremely large or it's like impacted, embedded into the urethra and causing issues. Page 409 in your ATI goes over diets with kidney stones, so make sure you take a look at that. Urinary retention. This is when the bladder cannot empty itself completely. So they go to the bathroom and there's urine left in the bladder. How do you think we diagnose this?
Would you use a bladder scanner?
100%. That magical piece of equipment that you can never find, and it's like the rarity on the floor, it just disappears and grows legs, and yes, the bladder scan. We have the patient void, and then we take the little bladder scanner probe, we put it over their belly or over their bladder, and we see how much urine is left over. And that's how it would be diagnosed. So adults 60 and over may have up to 500 or 50 to 100 mLs of urine after voiding. We typically want that empty. So when we do a bladder scan, what we're measuring is the post-void residual, that PVR, and it should be close to nothing. We're hoping that it's close. There might be like 5 mLs, but that's not significant. Other causes of retention, a lot of times prostates are a big thing. Like if there's a prostate issue, it can cause urinary retention, damage to the urethra, or any type of other neurological disorder. There's many causes for holding on to urine. Sometimes the reason why when we take out a catheter, we always bladder scan you after to go to the bathroom to make sure you're still not retaining urine. When there's a catheter in place, your bladder gets lazy. It's like, cool, I don't have to do anything now. Urine's just gonna come right out. I don't have to stretch. I don't have to do anything. So when the catheter comes out, we want to make sure that the bladder is emptying completely because it's doing its job. So we would do those PVRs. Symptoms of retention is going to be the need to going to the bathroom. You have that urge, but then you don't have a really good stream. It's just like a little trickle. It's real slow, but you're having to go to the bathroom all the time. Complications of urinary retention are going to be that hydronephrosis, that swelling and enlarging of the kidneys, and potentially a urinary tract infection. Urine that is stagnant, sitting in a place, not getting out is a cause of a UTI. So urinary retention would put them at risk for a UTI. And then urinary diversion. So we talked about ostomies. This is an ostomy that will drain urine. So this can be in any number of places for any number of reasons. If the bladder has cancer, we can do a urostomy. If there's a birth defect or trauma or something else going on, this ostomy can be created to allow the flow of urine to come out. This is an example of an ileoconduit. So it's going to drain the urine. It has a pouch, same rules apply, watching the skin, watching the stoma, emptying frequently. They're pretty, I don't want to say they're common. I've seen a handful of them over the years, but they do exist. So ostomies aren't just with stool.
How much does that pouch hold?
That's a smaller pouch. Some of the other ones can be much bigger. It truly is equipment dependent, production dependent. And it's
Yeah,
a
it
really
looks
good.
small to me. That's why I was like, that's not very
Yeah.
much. You'd be like emptying it all the time.
Yeah, I think they're not as big as colostomy bags. They're thinner. They usually, like nephrostomy bags will hold like 500 mLs in them. They're about this wide and like this long. But yeah, I think this is just a poor picture. All right. Let's do another I and O question because we've been talking about eyes and O's all day. So go through this and just send me a DM in the chat, just to me, with your intake and output. Unless you don't care who sees it. Sorry, my Zoom like just went on me. So I'm sorry. Where was I? Here we go. Somebody sent me something. I tried to click on it and it didn't open. So, okay. Nobody left.
I keep trying to message you. It just keeps saying that you're not in the direct messages.
Okay, so I got a whole bunch of stuff coming in. All right, so let's take a look at this. Maybe. There we go. So how many mLs are in the 8 ounces? Sorry.
240.
240. So he had 1, 2, 3, 4, 5, 6, 7, 8 ounces. So that's 8 times 240, which gives us a whole heck of a lot. Plus 24 ounces. So what did you guys get for total intake?
Is it 2640?
Oh, shit, what did I do? 2640 was our intake. Our total output's a lot easier to calculate. We had 2,300. So that left us with a net balance of 340, which I think I got a couple of those. Okay. That's it. All right, so questions on any of that stuff? Okay, well, I got a couple more poll questions for you guys, so I'll go ahead and give those out. Not that one, not that one. Sorry, that's okay, don't worry about it. Everything's being so sassy today. I just found out it's supposed to snow here tonight too, which makes me very upset. It's supposed to get like an inch, but it should melt. They said don't even shovel, which I wouldn't anyway. Okay. So kidney stones, what preventative measures would we want to teach? Increasing that fluid intake. We're not going to encourage a high calcium diet, especially if we need to know what kind of stones they are. And even so, that wouldn't be the route that we would take. And eating small meals, several small meals a day is great for GERD, but it has no bearing on kidney stones. So, go. Okie dokie. So, what principle should guide the nurse's management of incontinence in older adults? That urinary incontinence is not considered a normal consequence of aging. Yes, we see it. Yes, it happens, but it's not normal. Not everybody that goes through that. We don't catheterize for incontinence. Pericare, frequent changing. redistribution of fluids. You know, drinking a whole bunch of water before bed, probably not the best idea. And we wouldn't discontinue diuretics just because they're incontinent either, because they need them for a reason. Okay.
I got booted out on the I's and O's, the I and O question. Can you tell me what the answer was?
340 was the net balance. It was 26 something. I'm so bad with numbers.
40.
There we go.
And then
I think,
2300.
yep, 2300 for output. Okay, hemodialysis, AV fistula, what is most important? We want to make sure that taking a blood pressure can damage the fistula. So of those options that are there, they typically don't have pain with dialysis aside from like the insertion of a needle, but for the most part, they don't even complain of that. And a lot of times they use like that EMLA cream to numb it. And we absolutely want to use a stethoscope to auscultate, because again, just using your ear would be weird. Okay, here's a good one. Ooh. Okay, so which assessment findings should prompt the nurse to inform the physician that the patient may be experiencing signs of an AKI? That is going to be that the average urine output has been 10 mLs for several hours. We got something going on with those kidneys. With acute kidney injury, you're not necessarily going to have UTI symptoms like cloudy urine with an odor, or issues starting the stream of urine. Our dead giveaway is going to be low urine output, that oliguria. Remember the oliguria stage? All right. Ooh, I forget what questions I put in here. And I just did them yesterday. I got a crap memory.
Can I ask a question?
Mm-hmm.
On your email, it just said, I noticed it said the exam would be mostly diabetes and obesity with some GU questions. So is there like it's just not as heavy on the test, this chapter?
No, the review was going to focus more on diabetes and obesity, but the exam is all three. It's pretty divided into thirds.
Okay, that makes sense. Thank you.
Yeah. The review, I wanted to focus more on diabetes and obesity because that was further out versus you guys having this content this week.
Okay, I see. Thank you.
Okay, so we got glucose in the urine. What would we want to assess for? Winner, winner, diabetes mellitus. When we have glucose in the urine, that's usually because we have high blood sugar. Diabetes insipidus actually doesn't have any issues with blood sugar. It has to do, it's a neurological issue. Same thing with SIADH, which you'll get next semester. And renal carcinoma is cancer of the kidneys. And blood glucose would not be in the urine with that either. Ooh, here we go. Long term. Select all that apply. That's the word I was looking for. Ooh, we got lots of participants on this one. Okay, so what interventions should the nurse introduce into the program? Hand hygiene prior to patient care. Absolutely 100%. Assist the patient with frequent toileting. Yes, that prevents incontinence by having them go more frequently. Encourage them to wear briefs. No, briefs trap bacteria. It's like, think of it as like if you peed your pants, sitting in that urine there, trapped. It's a breeding ground. We use incontinence pads, repositioning, cleaning, but we don't want them. Briefs are bad. If they are incontinent, insert indwelling catheters. No. And provide careful perineal care, 100%. Okay, I think I have one more. Oh, no, wrong question.
I feel like that's a hard question. I was like, I'm gonna go with my best guess and we'll see.
There's a key word here. These are those questions that I do hate as a student because, oh yeah, like I feel like this could be a couple things, but greatest risk. So that being said, we'll go ahead and set this one out there. Greatest risk is going to be your patient with diabetes and poorly controlled hypertension. Diabetes, hard on the kidneys. Hypertension, hard on the kidneys. So yes, UTIs recurrently could cause some issues, but not as much as two really hard diseases on the kidneys, if that makes sense. Obesity has no bearing on kidney disease. I mean, it has, if it does, it's minuscule. And COPD doesn't as well, it does not either. So
I have a quick question about that one last time. That last question we had. So you were saying that although the recurrent UTIs are a big deal still, you would just look for kind of a bigger situation. Like the DM and hypertension are pretty big deal. So, okay. Awesome. That's what I went for, but I didn't know if like the reasoning as to why. So thank you.
Yeah, they're more likely to cause kidney issues than a UTI is basically what it comes down to. We know diabetes just obliterates the kidneys, and hypertension, heart and kidneys. When there's an issue with one, there's an issue with the other. So more risk factors makes them a greater risk. Last one. Oh, and if you have to go, go. Sorry, I just saw the time. Okay, so suspected urinary obstruction, incomplete empty of the bladder will cause what? This is going to be that hydronephrosis, that whole backflow that's going to cause the swelling of the kidneys. Alrighty. Well, what questions? Yes, I have a lot of stuff I have to post, so I'm going to blow up your announcements, which is one thing I don't like doing because they get lost, and I know that they get lost, and I wish there was a better way for me to post things, but there's not. So yeah, I have to.
No, I appreciate it though. I feel like the stuff you post is like very beneficial and to the exams too. So thank you.
Good. Good to hear. So yeah, I have a lot to. I'm sorry for blowing up your inboxes tonight, but I got a lot of stuff I got to send out there. So if there are questions, let me know. Review session tomorrow evening. And then I'm also doing a tutoring session tomorrow morning if there's anything you need help with. So if that's something you want to do, sign up with the CTL platform to come. And then I might try to do something Friday too, depending on how things are going. Because I know this is a quick turnaround. I do, but it's honestly, I think it's better than 5 exams in 1 week or within like 5 days. So, all right. All right. Have a good day, guys.
Thanks again.
Thank you.